And my talk is divided into two parts. The first part, I thought we would cover the baseline scan. And what I've essentially done is recorded a live scan of a patient coming into the unit as part of Monash IVF. And then after that is imaging pearls. And I'm going to simply take you through findings that we see in the baseline scan, going systematically through the uterus, uterine cavity, fallopian tubes, ovaries, and so on. So the talk is divided into just an introduction, just to mention about Monash IVF, the baseline scan, and then to cover the key points of pathology, and then to finish up with some summary and some comments. Monash IVF group is now quite a large group of clinicians sprawled across Australia and also into Asia, and is proud of having achieved the first IVF pregnancy in the world with Carl Wood and John Leeton back in 1973. I wasn't there around that time, but I joined them about 28 years ago and have been in a dark room spending half of my time scanning in gynecology. So what I want to do is to take you through a video clip that lasts for 5 minutes and 52 seconds. And it's not a whiz-bang clip, it's just a regular scan that we would do in our unit when a patient attends and to go through an IVF protocol, or even a patient attending for ovulation induction, that we go through a process of booking the patient in for about 15 to 20 minutes of scanning. The appointment is 30 minutes long because it takes 10 minutes of paperwork nowadays. And then the examination is performed predominantly transvaginally. So they empty their bladder on arrival, and that's the instruction before they come into the scan room. And then at the end of the examination, some urine has accumulated in the bladder, and we just do a transabdominal to make sure we're not missing any large pelvic cysts sitting high in the pelvis or low in the abdomen. When you introduce a vaginal transducer, it's very important to do so slowly. And in doing so, when introducing the transducer, that you must have the scan live and ticking before you go anywhere near advancing the probe and pressing it on the perineum. Don't separate the process of imaging from introducing the probe. They have to go side by side because you have to guide the transducer into position. If you are clumsy in this approach and it causes pain, you will immediately lose the trust or faith of the patient for the rest of the examination. So it is a very important part. Plenty of gel, rest the probe on the perineum. And once you do so with the gel and the probe in the perineum, you will note that straight away, these echoes in the midline are the echoes of air and gel. And these are your beacon or guiding light to set the probe correctly to guide it into the vaginal cavity. Your other landmark here is the urethra. This is urine in the bladder, and this is the bladder walls. Coming in posteriorly, you will see is the posterior vaginal wall. I won't steal any of Matthew's talk on the anterior and posterior compartment, but these are landmarks that are important to me as I'm putting this transducer in real time in this patient. I then apply a little bit of pressure on the perineum, and the next step I do is I reduce my depth. And now I've got a very magnified image, and I'm looking at the movement of the gel and the air, because that tells me that that is the tract of the vaginal cavity. And as I'm now advancing the probe, I'm now seeing the posterior vaginal wall. And that's an important landmark in terms of identifying pathology. And then I advance the probe a little bit further. And when the probe is in more anteriorly, I can now see the anterior vaginal wall. I don't examine the anterior compartment or the posterior compartment at the beginning of the scan. I examine it at the end of the scan. Why? Because it's a tense moment when you're introducing a vaginal probe as part of a gynecological scan. You're aiming to advance the probe slowly and effectively, not causing the patient any pain, and then go on with examining the uterus, ovaries, tubes, and so on. And then when you're pulling the probe out, at that stage, the patient has relaxed into the examination, and then withdrawing the probe, you can examine for Gardner's ducts, paraurethral Bartholin's, and so on. We measure the uterus from top to bottom, front to back, and then we rotate our transducer and measure it from side to side as routine measurements of the uterus. We characterize the endometrium as proliferative, secretory, or non-specific, and we look for the contents of the uterine cavity. So what happened in this case is we saw scanning across the midline and the uterus that there was a slight movement of an echogenic focus in the midline. If you ever see anything like that and you catch it, hit P2, the cine button, and then you can cine loop review at 300% of their native rate, and you see the polyp sliding up and down the cavity. That will enable you to identify the connecting vessel, and then you rotate 90 degrees to bring an axial section through the uterus as you sweep from the cervix to the fundus of the uterus. And that will also bring into view the echogenic focus and tells you that it is truly a polyp, because then outlined by the endometrium surrounding it. Be cautious, because quite frequently we'll see an echogenic focus coming in laterally, particularly in the late proliferative phase of the cycle, that may give you a false positive diagnosis of an endometrial polyp. In examining the uterine cavity, the next thing to do is to increase your dynamic range and slide to see that the endometrial surfaces are symmetrical. The next stage is to acquire a 3D volume, and for this, I open my region of interest to include the entire uterus. Next, I set the quality to max, and as a general rule, when acquiring a volume of the uterus, I select around 90 degrees to 100 degrees. If it's a large multi-uterus with fibroids, I'll go to 120. But there's no shame in having to go to 120. It just takes longer for all uteruses. It does matter when it comes to the ovaries, and I will address that in a second. Once the polyp has stopped moving, I then ignite the transducer and I ask the patient to hold their breath. That stops the uterus moving, particularly in large BMI patients. And I look at the sweep across to see if I've caught the whole uterus. I then saved that volume. I don't examine the volume on the spot. I save it to the hard drive. And then I proceed with the examination. It saves as a multiplanar and a rendered image. The next step is I acquire in an axial section. And you can see now that I'm sweeping from the cervix to the fundus of the uterus. So I have to get some idea of what the size of the uterus is, and I have to point my acquisition plane at midpoint in the uterus. So half of the uterus is below down to the cervix and half up to the fundus is above. That's very important, because in an axial acquisition, you will need to use 120 degrees almost always, because you have to catch the entire uterus. And also in terms of axial acquisition, frequently your image will be far clearer than anything you will ever get on sagittal. And that's a matter of trial and error and understanding. Don't always just revert to sagittal acquisition of the uterus, go for transverse. In this image down here, which is the best image of this polyp on the VCI, and this was the axial acquisition, not the sagittal. So I've now acquired 2 volumes on the uterus, one sagittal and one on axial, and I save that to the hard drive. Next, from there, I move on to examining the ovaries. And it doesn't matter whether you start on the right or the left side, but before I do that, I want to show you that when you have acquired a volume and an axial section, to get to the coronal section, remember, it's the x-axis that you rotate on. So this is rotating on the x-axis in this patient. And when you look on the x-axis, you now have the coronal view of the uterus. Axial acquisition, x-axis rotation, and then you get the coronal view of the uterus. And that's a much nicer image of that polyp than I had on the sagittal image. From there, I move on to examining the uterine cavity with VCI A-plane. And this is a standard for every gynecological scan that I do. This is real-time 3D or 4D. And it allows me to see the movement of the uterine cavity, the movement of the polyp, but more importantly, the interface between the endometrium and the myometrium. That's particularly of value in patients with retained products of conception when you're trying to decide what is blood and what is trophoblast. The next is I put on color Doppler. When I'm setting my color Doppler, I'm generally below 6 centimeters per second, because I want to catch the tiny vessels that feed this tiny polyp. But also in the setting of adenomyosis, when I want to look at flow, I want to look at a less than 6 centimeters a second or lower to see vascularity within the myometrium. In this case, it was a polyp, and I can see the feeder vessel coming in laterally. Next, I take a sagittal section and I split it looking at the movement of the uterovesical pouch. I'm focusing my attention here as I press per abdomen, and I see the bladder sliding off the uterus. Next, I look at the pouch of Douglas, the posterior uterine wall, and the fundus to see sliding of bowel off the posterior uterine wall. I do that with a dynamic range set at 9 or a dynamic range set at 10. I've now finished the uterus. I go over to the right ovary, and as I'm scanning through the right ovary, your eyes are immediately fixed on seeing a fluid-filled space. Next, you're looking at this in a patient, in a baseline scan, you take that straight away as being a lead follicle. Once a follicle is more than 10 millimeters, it's a dominant follicle. And these, on average, in a natural cycle, the mean diameter of ovulation ranges from about 7 to 27 millimeters. We're at day 9 in the cycle, so this may be slightly larger than you expect. So you may entertain the possibility that this is a luteinized unruptured follicle from a previous cycle, or it may possibly be a simple cyst, a functional cyst carrying over from a previous cycle. The next I acquire is a 3D static, and I want to mention this all through my talk today, is when looking at 3D static that the definition that you get of the follicles, of the leading follicle, will always be greater with 3D static than it will be with 2D. And this becomes an essential tool in imaging and gynecology in our unit. So I save the volume. This is the third volume that I save. And then I move over to the left ovary, and I take a sweep through the left ovary on both a sagittal and axial view, taking the 3 dimensions and measuring the ovarian volume. From there, I take a acquisition in 3D, and for this, you need to be very cautious as to what the size is, the volume of acquisition. In this case, a narrow, slender ovary, I would choose around about 45 or 50 degrees acquisition. Why is that important? Because I don't want all the other fluid-filled spaces that are in the pelvis, which there are many, unlike the uterus. You've got all the veins and arteries and lymphatics that can confuse the picture, particularly when you're doing an automated follicle count. The next step I like to do is to compare in a single image both ovaries side by side. Now, what you would have appreciated is that the ovary on this side is multifollicular. There are greater than 25 antral follicles in this ovary, but what you may not have appreciated is this ovary is also multifollicular. And the reason that you didn't appreciate it was because your eyes were focused on the leading follicle. And this is an important point, that when you're seeing a leading follicle in an ovary, a nice juicy follicle, that it will compress the primordial or antral follicles. And for these antral follicles, you need to pay attention that in many of these are the lead follicle, that you can have PCO with a lead follicle. And I finish up the scan 5 minutes and 52 seconds later with a single image that goes on my report to the referring doctor. And that shows the leading follicle in a polycystic ovary in the top left-hand corner, the polyp in mid-cavity in a transverse and axial section, and the multifollicular ovary on the left side. And I label these and attach them to my report. When the patient leaves the room, I then proceed to the 3D assessment of the uterine cavity. And for this, I will choose the A plane with VCI static. And that's the second image that I will attach in my report. I now want to walk you through a practical approach on 3D assessment of the uterine cavity. Because if there's ever an example in obstetric and gynecological imaging where 3D is triumphant, it is with respect to the examination of the uterine cavity and with respect to the examination of uterine anomalies. Indeed, the current classification systems almost demand that we look at a multiplanar assessment of the uterus. So let me ask you a question, that when you go to work tomorrow morning to do a 3D assessment of the uterus, how do you do it? The thing about an awful lot of these classification systems is an awful lot of emphasis has been played on which classification system we use and what are the points of measurement, but not so much on the technique that's used. And I think these waters are really quite murky. I'm only going to show you 4 techniques, but there are 5 additional techniques for assessing the uterine cavity. I want to choose the top four, because these are probably the easiest and probably the most popular in routine clinical practice. When you start off with the assessment of the uterine cavity, I make the point that you go to about an angle of 100 degrees and you acquire a volume. When you acquire the volume, you end up with this picture, which shows a multiplanar display. When you do a Z-axis technique, you simply take the A plane and you turn it around the Z-axis. You select the B plane and you turn it around the Z-axis. You select the C plane and you turn it around the Z-axis. So you have your finger on the button for the A, the B, and the C plane. And watch what happens when you do that. I'm going to start off by taking the A plane, and I'm going to place the reference dot bang in the middle of the cavity. And I want you to focus on what's happening down here when I Z-axis the A plane and Z-axis the B plane and see what happens. Because what happens is it brings into view a normal uterine cavity. So how far do I need to rotate the Z-axis? The answer is you need to rotate it until the uterus is in a 3 o'clock to 9 o'clock position. So we take the A plane and now it's 3 to 9 o'clock. We then have to take this and rotate it into a 3 o'clock to 9 o'clock. So now that's in a transverse position, and ta-da, there you have it, a C-plane assessment of the uterine cavity. And the only reason you do a Z-axis on the C-plane is to turn the uterus so it's the right way up. And once you've got that, you then go on to a full screen display and you have a demonstration of the uterus in a C-plane. That's the Z-axis technique. The next one, which is you see popularly in print, is the rendered image. So I'm going back to my original volume by hitting the initial button, and then I select render. Now, when I do render, I am only interested in the A plane. I have no interest in the C plane, and I have no interest in the B plane. And because I've no interest in these, I do not want them wasting space on my screen. So I simply select the display option, which is to the right of your tracker ball, which will display the A plane and the rendered image side by side. Now, once I've got that on view, I've now got a rendered line. For most systems, it's a straight line, and I can shift the volume and move the volume so it comes into line with the rendered line, or either you can shift the rendered line. It's your choice. For me, I prefer to shift the volume and bring it in line with the rendered line. Because the uterus cavity is curved, you can then select the rendered line and make this green line a curved line. At the end of the day, you end up with a rendered image. Remember, this is quite a thick image that you're looking at, the rendered image of the uterine cavity, but you need to optimize it. And one of the other important points is that is not good, because you have to have the box incorporating the entire uterus. It's a very important point, because the box there corresponds to the serosa here. If you don't include this as being wide enough out here, you will cut off the serosa and you will miss out on uterine fundal indentation. That's the render technique. The next technique is the technique which I prefer, is where I select the A plane. I have no interest in the B plane, I have no interest in the C plane, and I have no interest in the rendered plane. I select the A plane and I make it full screen. I place my reference dot in the center of the uterine cavity. And your buttons are labeled here, X, Y, and Z, for those of you who use the GE system, X, Y, and Z. And I click the X button, the Y button, and the Z button. As I click, I rotate them. So I select here, and now I've done my Z-axis rotation. I now place the reference dot in the center, and I do a Y-axis rotation. And now I've got the uterine cavity, and then I move on to a Z-axis rotation. Sorry, that should be Z. And X here, my apologies, X, Y, Z. And the X-axis brings in these cervix into view. And when I've got my, just draw that again so I haven't confused you all, X, Y, and Z. So then I do a little bit of fine tuning, and the fine tuning means is I want to bring into view the endometrial myometrial junction here, 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 and here. And to do so, I apply two other techniques. I use VCI, and you vary in your thickness. Usually 2 to 3 millimeters is what I choose for most routine imaging. And then I use volume speckle reduction imaging. And now just watch what that does to your image. It gives you a better definition of your endometrial myometrial interface. It is a smoothing effect. The hypoechoic border between the two is now seen more clearly. And I may, after I've done this, do slight alterations on my X, Y, and Z axis. But this for me will provide the best definition of a uterine cavity using A-plane assessment. It is more laborious, it is a little bit more technical, but it is far more rewarding than the previous techniques that I've described. And the fourth technique and last technique which I've described is that using a OmniView. So in OmniView, you take the A plane, you have no interest in the B plane and no interest in the C plane. The advantage of OmniView is it's a render technique, but we're not using the render box in the bottom right-hand corner. We are creating our own render box by drawing a render line in the line with the uterine cavity. And you can choose it as thick as you want it to be. Again, the importance of it, this is a straight line VCI, this is a curved line VCI, but I much prefer the trace, or even better, is the polyline. And the polyline is you draw and you fix, draw, fix, draw, fix, and it gives you a very accurate way of drawing all the way up to the serosa. And once you've got the rendered image on view here, you then rotate with the Y. And as you do so, you've now got a full screen display. The advantage of OmniView is it will bring in the cervix more effectively than the other techniques. So they are, in summary, the techniques which are used in assessing as part of a routine baseline scan. Now I want to take you through as to what may be the findings that we may see in a baseline scan. And as I do so, I want to start by looking at a baseline scan at a normal ovary. We generally book patients in from day 5 to day 10. In this case, the study was in day 4 to 8, legitijupicabine, describing what is the normal volume of the ovary in the fertile years is 7 mils, ranging from 2 to 17 mils, with 11 follicles in each ovary, ranging from 1 to 36. As we well know, it's a common finding to see multifollicular ovaries. And we routinely look at the number of follicles that are present and we document them. We also document the number of the lead follicles. I don't have time today, really, but another way of assessing this quite quickly in an IVF unit is using vocal. In the setting of where we are doing a baseline scan in a patient who's under 40 years of age, and we see this sort of appearance where we're scanning through the ovary and all we're seeing is 1 or 2 antral follicles in this patient, and we find that the contralateral ovary, it's a similar appearance. This is a typical appearance in a 40-year-old or primary or premature ovarian failure, which is frequently related to multiple causes, either genetic, Turner syndrome in particular. We see a lot of Turner syndrome in the IVF unit, although most of these are streak ovaries. And then there are those who are related to autoimmune. But the other biggest group is patients who have had repeated surgery for endometriosis. We see a significant proportion of patients with premature ovarian failure. It is, however, not an ultrasound diagnosis, I must add. It's usually a story where patients come in with the history of having missed a period, they're amenorrheic, they have signs of estrogen deficiency and infertility. This is how they present, and it's usually, in many of these, they've had an FSH that's done on 2 occasions, separated by 4 to 6 weeks apart, and then we make the supporting findings on ultrasound of premature ovarian failure. With regard to ovulation, we routinely look at this with color Doppler assessment, and with color Doppler, go straight to power Doppler, so I don't use color anymore. And in the setting of using power, I've now shifted more recently to slow flow. And this is just a very quick and easy way of demonstrating tiny vessels, and easier at the setting of looking at these neovascularizations seen with ovulation. You can do a 3D. This is if you've got time on your side. It doesn't add anything to what I've provided already on radiant and slow flow technology. From there, you may see quite frequently a baseline scan, hemorrhagic cysts, and these are a dime a dozen. Important not to mistake these as being multilocular or mucinous cyst adenomas. They have a typical sort of wobble appearance to them. Some of them can look craggy and irregular, and to those young at heart and starting out early in their career, they may trouble you when you first see them, that they may have this spider web appearance, but they are avascular. The other, which you may see in an IVF unit, is you're sweeping across in this ovary from one side to the other, is you may see hemorrhagic collections existing beside the ovary. And these are quite unusual in appearance. You start thinking about para-ovarian masses. But again, if you use VCI static, it'll define for you the typical tissue characteristics of this being a hemorrhagic collection sitting beside the ovary. And this typically happens after puncture of the ovaries or oocyte retrieval. After oocyte retrieval in an IVF unit, you may also see subcapsular hematomas. And this is a picture of a subcapsular hematoma. You can define the capsule here by seeing that echogenic line of the ovarian capsule. And these are typically very tender in patients who present post-oocyte retrieval. Other findings you'll see quite frequently in young women is functional ovarian cysts. And if you see these incomplete septations, they have this sort of appearance where it breaks as you're scanning through the ovary. And on a 3D rendered image, this will give you understanding why that breaks on 2D. And these are a benign finding in the vast majority of patients. But surface rendered imaging gives you an understanding as to what you are seeing on a 2D image. Dermoid cysts are a common finding at a baseline scan, and you all know how these appear. They're quite striking. They have multiple different tissue textures. You see the fine internal ground glass echo appearance, the exact same as you see with an endometrioma. It is no different. mucin and endometrioma have the same appearances, and you have the linear echoes of hair, and then you have the fat. And how do you know that's fat? Because there's through transmission. But as you scan through this, not only is there through transmission, this fatty tissue, there is also shadowing. And in this, there's likely to be calcification or teeth. Similarly, I go straight to VCI static. And when I look in static, I see that typical ground glass echo appearance. There was a study suggesting if you look at this echogenic fluid within the cyst, that seeing streaming is a feature which may enable you to distinguish endometriomas from other cysts such as dermoids. And there's, in a sense, we've learned there's no truth to that. Is looking at streaming inside cysts of no diagnostic value in distinguishing endometriomas. So when you see streaming in a cyst like this, which is quite striking, it's really of no value in helping you distinguish this. It starts out looking like an endometrioma, but when you look out to the side, you see this multiple different tissue elements of hair, fat, and calcification. This is a typical dermoid of 7 centimeters, but they're not all like that. Dermoids can be challenging. When you see a sweep through this ovary of the multiple internal hyperechogenic circular pads of fatty tissue, this is what is referred to the billiard ball appearance of dermoid cysts. And they can be a bit frightening when you see them, but that is a typical diagnostic finding, almost pathognomonic of a dermoid cyst. And then they come in all shapes and forms. And in the interest of time, I'll skip through these. But in a sense, some of these may take on the appearances of endometriosis. But dermoid plugs or rotted Kansky nodules are a benign finding. What you've got to ascertain is, are there other features to form a discrete cyst with hair sebum? Is there a massive effect? Is it exophytic or is it centered within the ovary? That's an important practical point, because many of those who you send out a report with a dermoid will find themselves at the end of a laparoscope the following week. And if you comment on your report that this is not visible at external or superficial inspection of the ovary, that might save them from a surgical approach. And they may also appear as a multilocular fluid-filled cystic structure. In this case, is a patient who was 32 years of age in a baseline scan, who I'd seen on 3 or 4 previous occasions with recurrent dermoid with multiple surgeries. And now she'd presented now wanting to conceive by IVF. And the problem with her was reduced ovarian reserve. But if you'd asked me without knowing the history, what did I think of that? I would have said a mucinous cyst adenoma would be what I would have thought that was. And then there are the malignant dermoids. If you ever see any vascular components coming into a dermoid such as this, this should lead you to suspect of a malignant change within a dermoid. So we move on to endometriosis, and Matthew and George will be strutting their stuff on this in a second. And I won't steal anything other than to say that 51% of dermoids have a typical unilocular ground glass echo appearance. But let me ask you the question, what about the other 50%? Well, the other 50% are the ones where we get wrong. And that's why it's important for me to take you through these little pearls, because this is how they may appear. They may appear as a multilocular hypoechoic fluid-filled cyst. This was an endometrioma. If you see up to 4 locules, you should consider an endometrioma. If there are more than 4 locules, you should then consider a mucinous cystadenoma. It is unlikely to be an endometrioma if there are more than 4 locules. It may have a layered echo appearance as this one, mimicking a hemorrhagic cyst. It may have a wall protrusion. It may be bilocular. It may have solid components within it, and it may have clot retraction. Clot retraction absolutely exists within endometriomas and can mimic a hemorrhagic cyst. So you see, for the other 50%, they are challenging, but just bear those in mind as possible differential diagnosis the next time you see an endometrioma. I will give maybe 2 minutes to the topic of decidualized endometriomas, because we see a fair number of these and they create an enormous amount of concern. When you see a cyst containing multiple nodules or excrescences on the inner surface of the cyst, the first thing I always think of in the setting of a young patient with unilocular confined to the ovary is a borderline ovarian tumor. But these, for the most part, are endometriomas, particularly in the setting of a patient who's had a previous history of endometriosis. There are 5 key points you need to know about these. Number 1, they increase in size during the pregnancy, the first trimester and the second trimester. Number 2, they decrease in size in the 3rd trimester and after birth. Number 3, the papillations increase in size in number in the 1st and 2nd trimester. And this is when you and I see them, and this is where you and I are troubled about the possibility of a borderline ovarian tumor in a young woman. Color Doppler increases in these, and therefore I don't think it's that helpful in helping you to distinguish between the two diagnoses. And the ground glass echo appearance is far less striking in endometriomas during pregnancy. With regard to fibromas, as we come down to fibromas, they are benign solid ovarian tumors. We see them in a IVF population. Most, however, occur in the postmenopausal phase, but about 40% of them are premenopausal. And increasingly, we are seeing these in women in 35 years of age to 50. We're seeing ovarian fibromas. They are typically round or oval with stripy shadowing, just like a fibroid, and they have minimal vascularity on color Doppler examination. So this is a patient who's presenting pre-IVF who has grossly enlarged multifollicular ovaries, and this is the uterus drawn in the same size frame. You can see the ovaries almost the same size as the multifollicular ovaries. It was a 31-year-old who's had polycystic ovaries since she was 15, and this was the solid mass, which was an exophytic fibroma arising from her ovary. So these are a little bit of nuisance value in terms of sorting these out before a patient embarks on an IVF cycle. Cystadenofibromas are uncommon, and I think I'll just spend a very quick minute on this. They are also mimickers of borderline ovarian tumors. And the thing that you see about these, unique about these, is they are craggy, irregular projections, which may demonstrate color. But the key distinguishing feature on these is that they demonstrate shadowing when you look at the papillary projections on them. And that's the important thing that you look for with a cystadenofibromas. Mucinous cystadenomas occur in young women, and these are therefore seen in the IVF population. And when you see that multilocular appearance in a 27-year-old who's presenting for a baseline scan pre-IVF, you know that the first thing that she needs to sort out is her multilocular ovarian tumor, and these can be quite striking. You would not sit on that at any length of time, even knowing that this is a mucinous cystadenoma. And if anything, mucinous cystadenomas have much greater malignant change when compared to their serous counterparts. When we look at the cavity of the uterus, we're looking to see whether there's any presence of devices, and yes, we do see IUDs in patients attending for a baseline scan for infertility. We particularly see these when they are coming from overseas, where they've had the device placed and they haven't known about it. And this is an IUD with a typical appearance of a marina, and in the bottom left-hand corner demonstrating the rendered appearance of the marina sitting perfectly inside the uterine cavity. The power of transparency. This is a copy multi-load, which you can demonstrate very nicely, and then the more recent devices. By putting saline inside the uterine cavity, it allows us to ascertain as to where the position of the polyp or the fibroid is, and Emmeline will be walking through that with us in a little bit more detail. With regard to false positive diagnosis, I think it's important to mention these because quite frequently you will see an echogenic focus in the uterine cavity. This happens particularly in the proliferative phase of the cycle. When you look at the late proliferative phase of the cycle, you see the effect of progesterone, where you see these hyperechogenic foci pointing up from the cavity. This was a patient who was booked for IVF in the States, where they request all patients have a saline performed prior to sending off the report and then embarking on treatment. And we see many of these coming through the unit. And when you look at the saline installation on this patient, you will see that in fact, echogenic focus is not inside the cavity, but is rather in the endometrium. And this is the same patient showing following saline installation of the uterine cavity. As you infuse the fluid, you will see that this echogenic focus is actually in the endometrium. It is not in the uterine cavity. And that's what helps you distinguish whether you are looking at a polyp or whether you're looking at a change in echotexture of the endometrium. Asherman syndrome is an important diagnosis to make, and for many of these, they can be subtle. They can be a single focal point, and what you're looking for is just a hypoechoic area and a deficit in the endometrial stripe. And as you sweep across, there's your hypoechoic space, which you see is a dropout in the midline. You also see lines and buds of endometriosis, of adenomyosis in this patient. And as you sweep across these, you come here, you see here's your hypoechoic line here running right across the uterine cavity. And anytime you see that, your next step is to then to move to a 3D acquisition and then after that to move to a saline. And this is showing a 3D rendered image of the same patient acquiring 100 degrees, asking them to hold their breath. She had a previous history of a suction termination of pregnancy at 13 weeks of gestation, which was apparently uncomplicated. And here you can see the very significant Asherman's in this patient. Some of these may also present with placenta accreta. Patients who've been through a manual removal of the placenta will have parts of placenta embedded that ultimately become calcified. And this is another cause of patients presenting with Asherman's. I'm sorry, I've run a little bit out of time for my myometrium, namely adenomyosis and fibroids. We will cover that another day. And I'll move to looking at the tube leading into Emmeline's talk. As we see here, there's some fluid, free fluid in the pelvis post-ovulation, and this allows us to see these finger-like projections of the fallopian tube. And in the bottom left-hand corner shows a rendered image here outlining the fimbria of the fallopian tube, and this patient is a pre-IVF baseline scan. For most patients, however, baseline scan there day 5 to day 9, but if there's a question of a uterine anomaly or intracavity pathology, I then book them in the secretory phase of the cycle, because this allows me to look at the fluid within the pelvis, look for ovulation, and then determine more accurately the uterine cavity. In this patient, you see a tuberocystic space in the pelvis, and you say to you, is that ovarian or not? Well, as you look towards this, the cavity suddenly fills up with fluid. But when you started the scan, there was no fluid in the cavity, but at the end of the scan, after pressing on the adnexa, on the hydrosalpinx, the cavity fills with fluid. And this is a typical appearance of a hydrosalpinx where the fluid is communicating with the uterine cavity. And of course, this is creates a very adverse environment for IVF. And in a situation of bilateral hydrosalpinges of these size, the treatment option for these would be to excise them by doing either a Vinci clip, or either by excising the fallopian tubes. We also see other non-gynecological pelvic pathology as a part of the gynae scan. This is sweeping across a 37-year-old who tended for a baseline scan. And here's a tuberocystic structure with that typical stripy appearance of mucin. And this is the appearance of a mucocele of the appendix. And we have a good number of these that we've seen over the years. And then finally, fimbrial cysts or dam nuisance. They're very frequent. They sit right beside the ovi. And from your point of view, the importance is not to mimic them with ovarian follicles. It's important to get your follicle count correct. And these sit juxtaposed to the ovary. And simply by increasing your dynamic range and pushing, you will see that fimbrial cysts sit beside the ovary and are easily to push and manipulate. Peritoneal inclusion cysts, is my closing slide, are common in patients who've had previous surgery. You see these fine filmy adhesions. The fluid conforms with the shape of bowel, and these are not hydrosalpinges. But they're the two key features to look for: is the fine films, the adhesions, and the fluid conforming with the shape of surrounding bowel. So in summary, when doing an assessment of a baseline scan, have a systematic approach, be gentle in putting in the probe, use the ultrasound system to guide the probe into position, consider both doing transabdominal and transvaginal, and color Doppler examination is a very useful tool, particularly with the advent of radiant flow and the slow flow technologies. I thank you very much for your attention after that whirlwind tour through what you might see at a baseline scan with some pearls along the way. So less of me and more of Emmeline. So it's a pleasure to introduce a fellow and a colleague, Emmeline, who lives on the other side of Australia, in Western Australia, in Perth. And before commencing her career in obstetrics, in radiology, she commenced with her diploma in obstetrics through the College of O&G. So she demonstrated her interest in O&G very early in the piece. And she's currently in a private practice, specialist O&G imaging, and also a public appointment at St. Charles Gardner in Perth. She's the lead examiner for O&G imaging for the Royal College of O&G, and she's also chair of the Obstetric and Gynae Special Interest Group of the College of Radiology, a keen contributor to Radiopedia, which I'm sure many of you know. And she was awarded the Australian Society for Ultrasound in Medicine Sonologist of the Year in 2019. So she's certainly a radiologist with a committed interest in obstetrics and gynecology. And it's a pleasure to have you with us here today, Emmeline, who I will hand over to talk about all aspects relating to tubal patency and infusion sonography. Thanks, Emmeline.
Thank you. I'm just going to share my screen. Hopefully that will work well. And can everybody hear me? Thank you so much for the invitation to be here today. It's an absolute pleasure to be in such great company. As you heard, I am a radiologist with a very keen interest in obstetrics and gynae, and I am very privileged to be able to do both X-ray and ultrasound mostly, and I'll be sharing with you lots and lots of pictures of both techniques. And to me, actually, I feel as if HSG and Hycosi are very similar. For the patient, it's a very similar experience. So, and all the problems that we face with Hycosis, we see in HSGs and vice versa. So hopefully this talk will cover both. As Simon mentioned, I come from Perth, which is a very long way from Sydney and Melbourne, where Simon and Georgia, and it has felt like a different country, actually, over the last 2 years. These are my disclosures. So in the next few minutes, we're going to be talking about how we interrogate tubal patency, and I'm going to try and keep this talk really practical, and we're going to talk about things that we have to think about before, during, and after the test, and I will illustrate them with cases. So how do we look at tubal patency? We can look at it using X-rays, we can look at it using ultrasound, and we can look at it using surgery techniques. So with the X-ray guided procedures, that's called the hysterosalpingogram or the HSG. And I think what the main really advantage of HSG is that you can see both tubes at once. And if you're a beginner, it's actually pretty definitive. Whereas with the ultrasound techniques, which we're going to talk about, actually it's a little bit harder to learn. There's a much steeper learning curve, and therefore they may not be as definitive as the HSG. Now, the major disadvantage of the HSG is that there is radiation, and also the fact that it doesn't really examine the other parts of the pelvis. We can't look at the endometrial thickness or ovaries, for example. So that for a lot of people, that is a major disadvantage. Moving on to ultrasound guided techniques, you can use either Hycosi or Hyphosi, and I will describe both of these in detail. So as Simon mentioned, with the Hycosi and Hyphosis, we generally would do a full baseline scan beforehand. And so this is the main advantage to using using ultrasound to look at tubes, because we can pick up other pathologies which can be very important in the assessment of the subfertile woman. In particular, if you pick up a hydrosalpinx, there's a markedly increased risk of infection and PID post-procedure. So you have to actually decide whether you would actually go on and do the procedure or not. Certainly, some of my referrers do not want me to go on to do the Hycosi if I find a hydrosalpinx. With a Hycosi or hysterocontrast sonography, it uses ultrasound to actually look at the tubes, and it just uses plain saline mixed with air. And you do that through agitating it, and in doing so, it changes the echogenicity from hypoechoic to hyperechoic. And in doing so, you can see the tubes really, really well. So the main advantage of this is the fact that you get your full ultrasound beforehand, and you can look at all the pelvic organs, and there's no radiation. And the main advantage over a Hyphosi is that this is very cheap. Now, the disadvantage of a Hycosi is that looking at publications anyway, there's a slightly increased risk of this test being inconclusive compared with Hyphosi. So this is what the tubes actually look like with Hycosi scans. You can see you get beautiful images in good experienced hands. Now, moving on to a Hyphosi, which is a hysterosalpingo foam sonography. So what this is you use, I just use this brand called XM Foam, and basically you get two syringes, one filled with gel, one filled with water. You connect the two and you agitate it, and you do it. It mixes up in 10 seconds. You get this fluid, which is fairly viscous and more viscous than saline, and you can move it through the tubes, and you get excellent visibility, and there's less inconclusive compared with the Hycosi. So the major disadvantage of this is that it's very expensive compared with the saline. Now I'm just going to show you a clip of the Hycosi. So we've done this after a saline. You can see the foam is bright and white and echogenic, and you can see it in the cavity. You can see it here in the tubes. You can follow it. Hopefully you can see my arrow, and you can see it spill very nicely outside. So it's very simple. But with a Hycosi and a Hyphosi, what we have to do, we have to look at one tube first and then the other. So generally we start off with the axial plane, and then we see which tube fills first, and we follow that one. And it's usually pretty simple, but pretty quick. I'm just going to mention Lipido, which is an oil-based contrast, which is generally used under X-ray guidance, but we have started, I know Simon does, and I have started doing it under ultrasound guidance as well, and it works pretty well. So Lipido in its native form actually just looks like saline, so it's hypoechoic, but in this picture here, I've done it after a Hyphosi, so these are the echogenic bits, are the foam left over, and Karen, Mitzi, and other people actually do agitate this, and when they agitate it, it behaves in the same way as saline, in that you get very, very beautiful images of the tubes in it, and you can see them as an echogenic line. Moving on to surgical techniques. So this is the lap and dye, and this is really considered the gold standard for looking at the tubes. The advantage is that if there's a problem that is found, such as endometriosis or adhesions, that the treatment can be done at the same time. Now, the major disadvantage, of course, is that it requires a general anesthetic, and for the lady, it's a day off work, and in that way, it's pretty expensive. So I think people will be reassured to know that lots of papers have now shown that there is very, very good concordance of both Hycosi, Hyphosi, and HSG with laparoscopy in the order of 85 to 90%. And there is also very good concordance between HSGs and ultrasound techniques of looking at tubes. I mentioned before about accuracy of Hycosis and Hyphosis. They're both very, very good techniques and very accurate, but in some of the publications, there has been some evidence that perhaps the Hyphosi, the foam one, is a little bit more accurate than the Hycosi, in that you get less inconclusive results. So as a referrer, how do you choose between a HSG and a Hycosi? And I think it comes down to local accessibility. Where is your local expert? Do they have expertise in these techniques? And you do need a considerable amount of expertise, particularly with Hycosi. It comes down to, as well, to cost. And then the other things I think people should think about would be things like, if you suspect that there's a polyp or there's a major structural Mullerian duct abnormality, you should probably head for the ultrasound guided techniques, because that means that you can actually do a saline infusion first and give your referrer all the information as to looking at the cavity, looking at the shape, and you can basically do that for free before the actual tubal patency assessment. Now, I'm going to be a bit controversial here and say that if you think that the patient is high risk, or you think that the tubes are blocked, you might want to think about doing a HSG, because to me, a HSG is very much more definitive. And, you know, for the young person starting off, a HSG is definitely more definitive, and you're much more likely to see the tubes easily. So if you're thinking about things like, I did a lady the other day who'd had her tubes reattached after a previous tubal ligation, so a reversal of tubal ligation. We went for the HSG technique, and we could see the tube really, really well. Now, if the patient wants to enhance fertility above and beyond the fertility enhancements techniques of Hycosi, Hyphosi, and HSG, you might want to choose Lipido. In the Red Journal last year, the reproductive medicine subspecialists published a consensus statement about oil, and they have said that if oil is available, you should at least talk about it with your patients and offer them oil instead of water or both. So we're getting to the nuts and bolts of the talk. We're going to talk about the practicalities and what gives me lots of headaches when I'm doing the tests. And I like to think of it as what to do before, during, and after the test. So practicalities to think about before the test. As Simon mentioned, bookings is really, really important. The booking time, you have to make sure that she's booked at the correct time of the cycle. Day 5 to 10 is our preference in a lady with a 28-day cycle. At the time of booking, we give her lots of information. We give her an information sheet about the test so she can read up about it, and we give her information about analgesia as well. We also want to make sure before the test that she doesn't have any contraindications to the test, particularly pregnancy. You will be surprised as to how many of our patients actually get pregnant in between booking and actually doing the test. We are happy with a urine test on the day of the procedure. Of course, in some instances, if they don't get their periods, we require a blood test the day before. There are very few people with allergies, but it's wise to ask. And then I want to talk about the clinical contraindications. So you shouldn't really be doing an assessment of tubal patency in someone with active PID. And there are lots of people that recommend that you screen for STIs before doing the test. And I've actually put down here as well, along with the whole list of things that you should think about. I think you should think about hydrosalpinx, as some people do think that this is a relative contraindication to doing tubal patency testing. Now, in terms of analgesia, this is really interesting. When I was researching this talk, I found this Cochrane review, which looked at eight studies, which actually showed no significant difference between people who had analgesia and people with placebos. And certainly lots of people are trying all sorts of fancy things with regard to analgesia. I think for our patients, we suggest a combination of paracetamol and a non-steroidal, if only for the placebo effect. It's really important. It does help calm people down. Now, during the test, what are the practicalities? I would say to you that the setup during the test is crucial. If you have access to a gynae bed, that's actually so awesome. It actually drops the feet down, so actually you get much better access to the cervix, and it makes your job much easier. Now, I've put good lighting there. I think this is absolutely crucial, because if you don't see the cervix, you are not going to be able to cannulate it. So you can use your whiz-bang $5,000 light, or you can just go to Bunnings, which is our local tool store, and buy a $30 head torch, which works really well. I use both depending on the site I'm at. Now, I've put here spares. We need spares of everything. You need to be ready for anything. So I have speculums of different sizes on hand. I have different catheters on hand, which we're going to talk about that in a sec. You should have different, lots of extra contrast just in case you need it, extra batteries, bulbs, and I have forceps on hand just in case I need to grab the cervix or clean the cervix of mucus. As always, it's really important to make sure that everybody's well versed in resuscitation techniques. Obviously, they are rare, but it's really important, if only for accreditation of your practice, to have resuscitation gear on hand. And obviously, don't wear your nice silk gown when you are doing this test. Now, I want to talk about patient preparation. Simon addressed this issue doing vaginal scans. It is so important. This is the first thing I tell my registrars when we are teaching HSGs. We need to make sure that the patient feels comfortable. And this is really important because they feel so vulnerable with this technique that it's really important to make sure that they have an opportunity to get to know you slightly before you start doing stuff to them, which is pretty invasive. So I would say I spend a lot of time chatting to the patients to make them feel as comfortable as possible. And also, I just feel, and I have absolutely no unscientific basis for saying this, but I just think that if a patient is relaxed, I feel that there are less vasovagals. I don't know if that's how I'm going to do a study, but if anybody is wanting to collaborate with me with that, please do. I will want to do a study on this one of these days. Now, speculums. I want to spend a bit of time talking about speculum size. I'm going to get sacked from ever doing a talk like this again, but I'm going to say that size does matter. And in this particular circumstance, the smaller, the better, okay? And the reason is that I think quite a few ladies actually have lots of pain from these procedures, from the speculum itself. So if you can make this procedure more comfortable for them, the better. And also, the smaller the speculum, you actually find that the reach of you get more control over the catheter because you're going in less deep. So really, if the lady is short and thin, you should start off with a smaller speculum. And actually, I usually go a size down if I'm not sure. And you just make sure that you choose a good size speculum, because actually if it's a right size speculum, the cervix ends up straightening better for you. I tend to remove my speculums after I get the tube in because it is much more comfortable for the patients. Catheters, now there are lots of different types of catheters that you can use. We stock these, but I don't personally like using them, the Christmas tree. I really like the Rocket HSG catheter. I'm not being paid by Rocket or anything like that, but I do. This is my standard catheter that I use, which I love. I've used it for many years, and I think I can say in this forum that Cook have actually going to stop manufacturing their HSG catheter for the people using Cook. They're going to have to change to a different brand, but this Rocket one is really good. So why I really like it is because it's just got a right amount of stiffness, and you can add to the stiffness with the guide here. So I find that this guide just gives the tube a slightly extra bit of stiffness so that you can catheterize the cervix without any problems. It comes preloaded with air. It comes preloaded with 2 mils of air, and it's already stuck onto that the right bit, so that obviously I don't inject that into the wrong I don't put contrast onto the wrong limb. I think it comes with a warning that you should not overfill this, and they're going to change the syringe, I think, to a smaller one because they found actually that people have been overfilling it. But the recommended amount is 2 mils. Now, this is another catheter that I really love having on hand. It's a hystrocone, and it's made by Rocket, but it's what I love about it is that it's got this metal bit which is rigid, and that sometimes, I don't know, I can't get the tube in using the standard catheter. I find that this is really excellent for problem solving. It can just sometimes get in where the other catheter can't, and you can see that you are supposed to put the cone, which can slide up and down according to the length of the cervix, against the external os, so you get a reasonably good seal. And the good thing about this is that it's Lipiodol compliant for the people using Lipiodol. What I do find, though, is that it's really quite hard to keep it steady, especially with the vaginal ultrasounds with the Hycosi and Hyphosi techniques. So in that situation, if I'm using it, I generally keep the speculum in and I hold the tube in firmly while we scan for the tubes, and it actually works an absolute treat, and it's got me out of trouble many times. Now, cervical cannulation. This is where all the traps happen. This is where most of the problems occur. So as I said before, I think you should choose your speculum size wisely, because in that way you can see the cervix better if you choose the right size speculum. Now, there are lots of problems with cervices. You can quite often you can't see it, in which case the pelvic tilt or the fists under the hips just tilts the cervix and makes it much easier to see. If you still can't see it, move the speculum gently around, and in 95% of the time you will be able to see your cervix. And obviously sometimes the cervix is very difficult to see because it's tucked off to one side, or it's pointing to the side, or it's acutely angled. And I've done it. You can see from my slides, I'm doing a lot of sighing here when it comes to finding the cervix. Sometimes you just have to be a bit flexible with the cervix, and I have actually done quite a few times actually done the procedure with the patient lying on the side so that I have good access to the cervix. The soft cervix is really difficult. If you find that it's soft and the tube is not going in, try the tenaculum to hold on to the cervix. You will find that it goes in easier. And just beware of the patient with the two cervices, and hopefully you will be aware of this because you've done your 3D ultrasound beforehand and you've seen the two cervices. Now, balloon placement. So during the so when you're blowing up the balloon, I would suggest that you inflate it really slowly so that you don't cause pain, because this is a really painful part of the procedure for most people. I like to put my tubes just in the distal cervix so that it doesn't slip out, but you get enough of a seal. Sometimes if you put it in the uterus, it can be pretty painful, but you will get a better seal for your contrast. Now, these are the problems that I've encountered over the years with balloon placement. So sometimes, particularly with the multiparous women, that the uterus is large, and so you're not getting a very good seal with the balloon, in which case you may have to inflate the balloon just a little bit more so that you don't get contrast coming out through the vagina. Sometimes the balloon may actually be too large for the uterus. I'll show you a case in a second of that, and you may need to deflate the balloon a little. And sometimes the tube goes off eccentrically, and you'll see one tube go off with enhanced before the other one. That is a problem as well, in which case you might want to pull the balloon back and you will solve all your problems. So this is a HSG case, which one of my registrars did a couple of weeks ago, and they were very enthusiastic and then cannulated the cervix really beautifully and well. However, we could see from the scalp view that it was hanging off to the left, and when they injected the dye, they could see that you could see that the dye was going into the left tube and there was absolutely nothing in the right. And you can see that the balloon was actually relatively large in comparison to the small uterus. So then, we deflated the balloon by just 0.5 ml, and then that allowed for the tubal spill on the right. So that was a lovely little easy thing to do. Balloon deflation, generally it's usually user error. That's usually me forgetting to turn the spigot off as we go. So it's usually I take full responsibility for that, in which case you have to actually just either cannulate the patient again or put in more air. True balloon failures are now quite rare, but if you do have that, make sure you talk to your rep about it. In terms of ultrasound hyphoses, my top tips are so I mentioned before that with the hyphoses that you have to mix up the gel with the water, and you mix it up for about 10 seconds and it becomes echogenic. I would say to you, don't mix up your water and gel till after you cannulate the cervix. It doesn't take long to do. The reason for that is sometimes you can lose the echogenicity of the fluid should the procedure take longer than you think. And a real top tip and really practical is don't lose the connector, because the connector, as you can see, is really transparent, and in a dark room, it's really easy to lose that bit. And I would say to you, inject really slowly as well, because that hopefully reduces the spasm. Now, during the test, Simon talked about, do we do salines first beforehand? I think this is up for discussion. I'm very happy to chat to people about this. I would say that I'm a fence sitter. I sometimes do and I sometimes don't. Sometimes if I see the endometrium really beautifully, it's gorgeous and thin, I don't really see much value in adding saline beforehand. I know some people in the audience will disagree with that, but if I see something like we in this particular patient, we saw a little echogenic structure, which we weren't sure whether it was just a corrugation of the endometrium or whether it was a true polyp. We put in water first or saline first, and you can see this beautiful demonstration of the cavity, and you can see that there's absolutely no polyp and that the cavity is normal in shape. So that is something to consider. I think the disadvantage, of course, is time. It adds a little bit of extra time to your procedure, and theoretically there's a slightly increased risk of infection. So during the test, if you don't see spill in the tubes, what do you do? I think the thing is you wait. You just have to be very, very patient because some of the tubes are very skinny and sometimes they spasm. So you just have to wait and make sure that the patient is comfortable, and you wait and you wait. This was done in our practice. This test was done in our practice a couple of weeks ago, and I believe the patient was very comfortable. They saw spill on the right-hand side, really easy. And then on the right, there was just absolutely no spill. So they just kept chatting and talking. And after a few minutes, they could then see the spill in the interstitial portion of the tube. And 12 minutes later, they then saw spill coming out of the tubes. So you just have to be very patient. Now, coming up to my next top tip, which is probably my favorite tip of all. If you don't see spill, what do you do? I'm very grateful to my friend Elika in the UK, who's an interventional radiologist, and she has taught me this technique is to use the villain's laugh. And there is the classic evil laugh, or you know, in this at Christmas time, you can try the ho, ho, ho. Whatever it is, if you get the patient laughing, it will generally help with the spasm. And honestly, this works so well. I've had 2 cases last week in which one under ultrasound, one under X-ray, in which we did this, and it was like magic. And I will show you this case that we did under X-ray guidance. So you can see beautiful tubal spill on the left, really, really quickly with no problems at all. And then there was absolutely nothing on the right-hand side. I decided to crack a joke. In fact, I think I talked to her about the evil laugh. And a minute later, you can see beautiful tubal spilling. And this is honestly the best tip of all. Thank you very much, Elika. It's a great tip. Okay, Buscopan, I'm going to skirt over this because there are some people that use it, some people who don't. I don't use it, but I know that some people do, and that it works really well to reduce spasm. I'm just going to mention intravasation, which is when you get contrast that's outside of the endometrium that goes into the muscle. It's you can see it on both really well on both ultrasound as well as X-ray, and it's not well documented, but it is more common than you think. There's a huge range of percentages in which the studies show that different percentages. We've just done an audit, and our intravasation rate's about 9%. It's important in that if you are giving Lepidol, so you should think about whether you should administer Lepidol. Should there be intravasation? Because it's fine if you're using water-based contrast, but you don't want it to intravasate if you're using oil. Most of the patients are asymptomatic with it, but occasionally you can run into big trouble with the intravasation. Another tip is that the posterior ovary is very hard to do when you are using a Hycosi or Hyphosi technique. So obviously, if the ovaries are sitting posterior to the uterus, you sometimes get lots of shadowing from the balloon or from the actual contrast itself. And sometimes you're just not really sure if there has been tubal spill. A good tip is to look transabdominally afterwards. And it's amazing that you can actually see the whole tube, sometimes the echogenic tube, and you can confirm spill. So after the tests, what do you have to think about? Watch for allergies. They are not very common, but it's something to think about. Anaphylaxis is vanishingly rare, and vasovagal are the most really important thing, which is not uncommon. As you know, you just have to make sure that you have facilities to care for your patients with vasovagals. If you're using Lepidol, just make sure you check their thyroid function, and we are going to talk a little bit about infection and antibiotic prophylaxis. So as Simon mentioned, some people do, some people don't. Do you or do you not? It just depends on your local practice. I would say that doing a lit review here, I found that there was a huge range of reported prevalence of PID following HSGs and Hycosis, for up to 44% in the unscreened population, so not screened for STIs, whereas the latest review, which was done by the Dutch group, and there was quite a few patients here, 5,000 patients that they looked at, they found that there was actually it was very rare, but actually interestingly, there were more infections in the group that had antibiotics compared with the group that didn't have antibiotics. Certainly the review, this was a review paper in 2016 by Pereira. They showed about a 2% PID rate following HSGs and hycoses. And interestingly, all of those cases occurred in patients with hydrosalpinx, and in patients with normal tubal anatomy, there was absolutely no cases of PID. So their recommendations was to consider doxycycline if there was hydrosalpinx, but they felt that there was no need for antibiotic prophylaxis if you don't see hydrosalpinx. Certainly the RANSCOG guidelines, which were revised early this year, do not suggest antibiotics. And I know this is controversial because we'll talk about this after this talk. So what about radiation? Just very quickly, I would say to you, if you're considering HSGs, the radiation dose is totally dependent on a whole heap of factors. Let's just say that usually with a HSG, the radiation is slightly more than that of a chest X-ray and slightly less than that of a CT abdomen. So it is very small, and it just depends on whether you think that is clinically important or not. So in conclusion, I would say to you that my top tips really are just to make sure that the patients are really comfortable when you're doing the procedure with analgesia, and really they're mostly pretty anxious. And I think if you chat to them first, you want to make sure that there is reduced spasm in that way and reduced pain. Choose the appropriate speculum size and inject slowly. Thank you so much to my colleagues for their tips and help with the getting the pictures. And I would like to thank you for your attention.
Thanks very much, Emmeline. That was a great talk. And there are many questions that are flowing in here online. So in the interest of time, I might get going with them and ask you the first question that comes in from Tui, asking, is the pain level of HSG, hycosy and hyphosi similar? And if I could preface that by adding on top of what Tui is asking, is in my personal experience, and that's many years ago that I've seen HSGs done, is that they were relatively painful procedures in comparison to, say, doing a foam. What is your take on that?
That's a great question. My take on it is that there is absolutely no difference between the two. I do both of those techniques on a weekly basis, actually daily. I do ultrasound 3 days a week and X-ray 1 day a week. They're all the same for me. And I've personally done an audit through my practice, and there's been no difference in pain levels between any of those techniques. The median pain level is 5.5 out of 10. And we actually document it in our reports, the pain level now. So we find it really easy to audit these patients. And I ask them every time, and there is no difference at all.
And I guess it probably relates to the experience of the operator, Emmeline.
Yes,
who's slick at doing HSGs and you're somebody who's slick at doing foam, there's nothing in it. And clearly you have that technique.
Yeah, I agree with you, Simon. It comes down to experience. And I think sometimes, if you're a radiologist, with all due respect to radiologists, if you're doing, one every month as opposed to doing 20 a week, you will not be as good at doing them. So yeah, it comes down to experience and care.
Can I ask you, in your reading, is there any difference in pregnancy rates across the different techniques that have been used? Is the question coming from Apostos?
I think that's a really good question as well. In my reading, there is no difference in pregnancy rates between the two techniques. As far as I'm aware, the pregnancy rates post both HSG and hyphosi is around the 29 to 30% mark. That's what I tell my patients. And you can increase that to about 40% if you use Lepidol. That's pregnancy within 6 months of the procedure.
Okay. And if I could ask you, in patients who you are performing both oil along with your hycosy, what additional benefit are you quoting when providing the service to patients with the Lepidol?
So with the Lepidol, I tell them that it's approximately a 10% increase in pregnancy rate compared to not using oil.
And in terms of the advice that you give them, Emmeline, as how soon can they start trying to fall pregnant after the administration of oil?
Yeah, there was a bit of concern about them not falling pregnant in the first month or so because of issues with thyroid. As far as I know, there is now no advice contrary to that, that they can try getting pregnant in the first cycle. Yeah. That's as far as I know. And obviously you want to make sure that you're monitoring them really well to make sure that there is no subclinical hypothyroidism, making sure that you follow up with their thyroid function.
Yeah. And I think if I could just add more comment, Emmeline, just with regard to the issue of the saline. As a general rule, we don't do saline before we do foam tubal patencies, but we don't do a saline prior to the foam tubal patency unless there is a suspicion of intercavity pathology where we're not sure what it is. If it's a straightforward polyp, I don't see the point. But if there's a question, there's an additional polyp, or there's a question of whether the fibroid is 50% submucous or not, we will then do the saline first and then proceed with the foam. But as a general rule, I don't like doing it because I find unless the saline has been warmed, which is not the case, we don't have the saline pre-warmed, is I worry about tubal spasm that has been affected by the saline by the time it comes around to the foam. Now, that's an anecdotal comment. I don't know if you would like to comment or you have had that same experience. So you do a saline, you can see the saline going through the tubes, but you want to do the foam to get that extra detail, and you go into the foam and you can't see the foam going through the tubes.
I totally agree with you, Simon. It seems like we work the same way. So generally, I generally don't do a saline first unless there is a problem, or we see a problem, or we suspect there's a structural miliary duct abnormality, or we think that there might be a fibroid. We want to look at the cavity. We don't do the saline first. I agree with you. It's just a bit of bother for very little. That's my experience, but I know people in town do things differently.
Okay. Thanks very much, Emily, for a fantastic talk. And I might just ask.
Can I ask something? Is that all right?
Sure.
I'm a fetal medicine specialist. So this is a little outside my area of expertise. But if you find that the tubes are patent, or if you find that the tubes are closed, is the treatment not IVF? And therefore, does it matter? Do you need to do tubal patency testing? What difference will it make ultimately in the management of the patient, whether the tubes are patent or not?
As far as I know, Aris, I think it makes a big difference, particularly with ladies who want to try ovulation induction first before they go on to IVF. It makes a really big difference as to prove their tubal patency. If they are going for IVF and they know they're having IVF, there's no point in proving tubal patency. But as Simon mentioned, a lot of clinics in the US actually want us to do saline first to make sure that the cavity is good. And certainly we found a few people in which we have found polyps and adhesions in doing the salines pre-IVF. But so it just depends on what the patients want. If it's IVF, we want to look at the cavity, we do salines. If it's ovulation induction, they want to try that first before they go for IVF. They definitely need to prove tubal patency first.
No, absolutely. No, I completely agree.
Sorry. Did I misinterpret your question?
No, completely agree that understanding the cavity being suitable for IVF is absolutely key. It was more specifically about the tubal patency. And yeah, I mean, I agree with you. Obviously, if the woman is going to try for ovulation induction, then that would be important. But yes, once you're down the track of IVF, I suppose it's less relevant. But yes, thank you for that.
Thank you.
Very, very clear, Emmeline. And I'm very jealous of you living in Perth in COVID harmony, and hope to see you again. I met Emmeline in Melbourne 2 years ago, and we were quickly going to meet up again but I managed to invite you back before you invited me.
Well, it's an open invitation for you to come to Perth. So when our Premier actually finally opens the borders and lets us out and let you in, we would love to have you in Perth in person.
Well, the reason that you're so COVID clear is because no one is allowed out or in. So
that is absolutely correct.
Thank you so much, Emily. Lovely to see you.
Okay, well, we might keep going. There are a few other questions that have come in from Mary McCaffrey, Shilpa, Vijay, and Louise Zaid, and we have these questions here, and we might keep going with the program. We'll hold them open when we open for general discussion. So we might go next. We have on the program Dr. Matthew Leonardi, who's been a great help to me, Matthew, in organising one of the meetings we had recently in Calgary, and he's a gynecological surgeon and sonologist McMaster University in Hamilton. He's an honorary adjunct lecturer at University in Adelaide, and he has published over 50 peer-reviewed scientific articles, several textbook chapters, and presented at several international congresses. Matthew was appointed as the World Endometriosis Society Junior Ambassador in 2020 and founding member of the Next Generation Committee at ISUOG. And what that really means is that Matthew's a gun. He's currently contributing to clinical practice guidelines in endometriosis for the Society of Obstetricians and Gynecologists. So Matthew is clearly a rising star in the field of ultrasound and particularly in advanced endoscopy and endometriosis. And it's a pleasure, Matthew, to have you joining us. I don't know what time of day it is, but I was very grateful when you said you would be able to join this meeting, but I knew it was at an ungodly hour. I'll hand over to you, but thanks for joining us, Matthew.
Thanks, Simon. The time doesn't matter. If there's an opportunity to talk about ultrasound and endometriosis and how we can advance things, the time doesn't matter. I'll be there. Thanks to the organizers for the invitation. Thanks to Simon for doing all of the coordination, and to my co-speakers. I'm going to be talking with you about specifically one of the subtypes of endometriosis, which is the most common subtype. But maybe we'll just ask Simon, has George's lecture already been played? I was asleep at the very beginning of all of this.
No, we put George's lecture to the end, Matthew, okay. So you're proceeding. So
okay.
You have the opportunity to listen.
Sounds good. So for the listeners today, there's a lot of content around endometriosis and imaging in particular. And of course, endometriosis is probably the most common cause of infertility. So it is one of the most relevant to talk about today. My talk is going to focus on the subtype of superficial endometriosis, and George Condis's talk will focus on deep endometriosis and adhesion states in the pelvis. And so you'll get that content after mine, but I'm happy to answer questions on all types of endometriosis. I will share screen.
Yep, I've got it.
Okay. So again, my name is Matthew. I'm from McMaster University in Hamilton, Canada, where I work as an assistant professor in gynecological surgery as well as ultrasound. And I did my fellowship with George in Sydney, which is how I got connected to these amazing Australians. I do miss Australia a lot at this point, especially. Here are my disclosures. And if anybody's interested in connecting with questions or just through social media, please don't hesitate through Twitter, Facebook, Instagram, or even YouTube, where I put a lot of my lectures. To start, I thought I was going to first emphasize the growing importance of diagnosing endometriosis for the infertility patient population. This is a very new study, actually, that just came out this year from an Australian group in Queensland, which has been able to help us really hammer home how important the diagnosis is. before assisted reproductive technologies. I've put a QR code here. So for those of you that are familiar, go ahead and use it. For those of you not, all you need to do is open your smartphone device camera, shine your camera at the QR code, and a link should pop up somewhere on your screen. When you click that link, it'll take you directly to the article. And I recommend you do that because I think this is going to be an article that we all need to read and use in the advocacy of diagnosing pathology, specifically endometriosis in the infertility population. But in short, this was a big study of individuals who underwent assisted reproductive technologies who had endometriosis. There was a dichotomy of those in the study, those who were diagnosed with their endometriosis before their assisted reproductive technologies and those who had a diagnosis at some point in their life after their ART. And the study outcomes focused on the ones that matter most to patients, which are things like live birth rate, clinical pregnancy rate. For those with endometriosis who had a diagnosis before their ART, their outcomes were equivalent to those who had ART but had no diagnosis of endometriosis at all, which is a really good outcome to have because endometriosis complicates the ART process. For those who had a diagnosis of endometriosis after ART, they had worse outcomes than those who did not have endometriosis. They were more likely to need to use IUI, they were more likely to do more cycles, and unfortunately, and most importantly, they were less likely to report a live birth. So we believe, amongst a lot of us here, that diagnosing gynecologic pathology is very important, diagnosing endometriosis is very important. But this study really tells us that diagnosing it as the reason for their infertility and before they undergo their assisted reproductive technologies is really important. There's a need to talk about the subtypes of endometriosis when we focus on ultrasound diagnosis of it, because things that are generally larger are thought to be easier to see. In the past 20 or so years, there's been an insane increase in research on diagnosing deep endometriosis using ultrasound. George Condas has been a major player in that field. Historically, deep endometriosis was defined as 5 millimeters of depth or more to the peritoneal surface. And this is where the diagnostic accuracy studies started to classify something as deep endometriosis versus not deep endometriosis. And that threshold allowed us to identify diagnostic performance of imaging techniques, including ultrasound. There are groups historically that have not classified deep endometriosis as 5 millimeters or more, but rather other definitions such as endometriosis in fibromuscular tissue. And now we have a brand new terminology consensus that defines deep endometriosis as any endometriosis that extends under the peritoneal surface. This changes the game a little bit because that measurement of 5 millimeters that has historically been used is now being essentially thrown out the window. Are the diagnostic test accuracy studies that have historically been done going to be as relevant? Because if something was less than 5 millimeters and not classified as deep endometriosis, would that change our sensitivity and specificity? These are intricacies that people like myself and George, who are doing these diagnostic test accuracy studies, think a lot about, but they have a lot of clinical relevance. I think the latest definition is probably going to enhance our diagnostic accuracy, but it does change how we interpret some of the previous studies. For those of you that are more living in the ultrasound world and not the surgical world, I always do like to show what endometriosis looks like on surgery at laparoscopy. Here are depictions of superficial endometriosis. We have classic subtypes of superficial endometriosis: red flame-like lesions, blue-black lesions. There are lesions that are clear vesicular lesions. You can almost not see these at laparoscopy either. They're very difficult to see. And then we have more white type lesions. These are thought to be more old, fibrotic. We have lesions that are called peritoneal pockets, where there's defects in the peritoneum that are created. And then here in the bottom right, we have adhesions. In some cases, you have a medley of the various types of lesions all in one. Where does superficial endometriosis exist in the pelvis? Everywhere. It can exist everywhere in the pelvis, everywhere in the abdomen, on the bowel, all types, on the diaphragm. And so we're not going to be seeing all of that using our imaging, but there is a propensity of superficial endometriosis and all endometriosis to exist in the posterior compartment of the pelvis, behind the uterus. In a study that we've done in Sydney, and I'll show you a little bit more details of this study later, we looked at where was the superficial endometriosis specifically. And the main area is the lowest parts of the pelvis, the pouch of Douglas, peritoneum, the paraovarian fossa, both right and left, or also called the pelvic sidewall. We have it in the pararectal space, peritoneum, and the uterosacral ligaments. Those are the most common spaces. And so when we think about how do we diagnose it, we have to look at the most common spaces. So now I'll talk with you a little bit about how we have started to perform ultrasounds, specifically looking at superficial endometriosis. My first tip is to spend most of your time when assessing for superficial endometriosis in the posterior compartment of the pelvis. This is behind the cervix. In most patients who have an anteverted uterus, the probe will have a tendency to settle into the anterior vaginal fornix. This, of course, is going to allow you to assess the uterus really clearly. You get a nice perpendicular view. You can assess the anterior compartment, the bladder specifically, with the probe there. And that's generally because the anterior vaginal fornix is a bigger space when they have an anteverted uterus. In somebody who has a retroverted uterus, the probe does have a tendency to settle into the posterior compartment, the posterior vaginal fornix. So you get the advantage there, but most people don't have a retroverted uterus. So you have to make a very strong effort to get the probe into that posterior vaginal fornix by kind of diving behind the cervix. This can be rather painful for individuals at baseline, and those with endometriosis or chronic pelvic pain even more so. There's a stretch on the uterosacral ligaments that happens when you put that probe in the posterior fornix. So I recommend going slow and talking them through that process. But this area is where most of the disease is going to be, deep and superficial. So it is really important to spend time there. Otherwise, the diagnosis will be missed. The second tip is that we should capitalize on fluid. And this is something that comes as a nice tip following Emmeline's talk, where we are introducing fluid into people's pelvises, and we can capitalize on that. And I'll tell you a little bit more. But when you have fluid, subtle things that may not be so easy to see when there's the absence of fluid start to pop. So here we have a few little hypoechoic lesions within the uterosacral ligament. My mind now is questioning, are these truly superficial endometriosis or deep endometriosis based on the change in terminology? But regardless, these are really subtle things to see that we are seeing more clearly with fluid. So on that note, we can sort of decide about when we're going to be timing a scan if we're thinking about superficial endometriosis. There are three possible scenarios. One, you don't care, you scan when you scan and you see what you see. The second is to consider a post-ovulatory scan for those who are ovulating, which of course can be challenging in a fertility population because some of them don't. But when there is an ovulation event, usually there is free fluid settled into the pouch of Douglas. The third option is to capitalize on the other tests that people are undergoing for fertility. So those are your saline infusion sonohystrography tests or your Hycosi tests. And truthfully, this is when we started to appreciate these subtle features by doing these tests over and over and seeing that fluid settle into the pouch and starting to look at the structures in that space with more detail. Essentially, we have taken the saline infusion sonohystrography and Hycosi test one step further and created a test called saline infusion sonopodography with the intention of putting fluid into the pouch of Douglas via the patent fallopian tubes, and specifically assessing that space there. So here we have a view of the posterior compartment following the infusion of fluid, saline, in patients who have infertility. In the left image, we have the probe pushing into the posterior vaginal fornix, and we have that on stretch here. We have fluid settled into the pouch of Douglas, which is splaying the peritoneum of the posterior vaginal fornix from the rectum. We have the rectum, which is depicted here, the hypoechoic layer, and the content of the rectum just below. And in the retroperitoneal space, where the peritoneum ends, the rectovaginal septum or space begins. That's that white line there. So these planes all of a sudden become accessible because they're not touching anymore. This here on the right is a transverse view of that. And you can see really nicely, we have the vaginal peritoneum just here. We start to see the pelvic sidewalls. We start to see the pararectal space. And we see over top of the rectum, the serosa. For those of you that are interested in a really clear step-by-step approach as to how we performed sonopodography, this QR code will take you to that study. This was published in the Journal of Ultrasound in Medicine. And this was the jumping off point for us to better characterize that space and start the process of evaluating for subtle features in the posterior compartment, including superficial endometriosis. How have we defined superficial endometriosis? It's always defined relative to the peritoneal surface. And this was even before the new terminology came out, because we know that superficial endometriosis is a smaller type of endo, and it's generally lining the peritoneal surface. It can line the surface of the other structures in the pelvis, including the ovaries and the uterus as well, though technically it's all peritoneum. So the most common type of superficial endometriosis is ones that come off of the peritoneum. And our first feature, this is the one that may be a bit more controversial based on the new definition, the hypoechoic areas that are within the peritoneum. These ones might now be not considered superficial, but this was one of our original definitions. Hyperechoic projections, I think, is the most common way that we're seeing superficial endometriosis. These are millimeter to millimeter white dots that come off of the peritoneum. Very small cystic areas, pockets of fluid, i.e. the peritoneal pockets that we saw, and filmy and irregular adhesions. This is the prospective diagnostic test accuracy study that we performed and published in the European Journal. This is a study that we performed using the highest quality diagnostic test accuracy methods. Essentially, what we have done in this study is we performed the index test, which was saline infusion sonopodography and laparoscopy, as well as histology. We know that surgeons are not always correct at what they see laparoscopically. What they biopsy is not always proven to be endometriosis. So this study was unique in that we had two reference standards. And the diagnostic performance did change, actually, and did interestingly improve with the histology as the reference standard. But what we did was we had Professor Condes initiate a laparoscopy. And I was outside of the room at this time. So we were able to obtain the reference standard of direct visualization first and foremost. Once that reference standard was acquired, the abdomen was emptied of all of the gas, and I entered into the room. All of the cameras were out, of course, and performed saline infusion sonopodography. And with everybody quiet in the room, I made my assessment and spoke out loud and documented on the board what I've seen. We then, at that point, were able to reveal to everybody what was in the pelvis, myself as the only blinded person, and decide whether we were right or wrong. Of course, that could have changed with the histology as a second reference standard, but in most cases it didn't. In those who we eliminated, which were those with deep endometriosis, ovarian endometriosis, and obliteration of the pouch, we did so because we already had a diagnostic understanding of their pelvis in a much better and reliable fashion than superficial endometriosis, which was novel and we were questioning. So when we eliminated those individuals who already had a diagnosis, these are our metrics. And this was the first study of its kind. So by no means is this, ready for prime time use. It certainly does require validation studies externally, but you can see how optimistic our values are here. Our accuracy compared to surgical visualization was 89%. Overall accuracy did drop with the histology, but our sensitivity increased from surgical to histological assessment. This overall to us is optimistic that we can see something that we historically did not think that we could see. If you read studies on endometriosis, firstly, most of the time they'll say that the only way to diagnose it is laparoscopy, which is false. But even amongst those who are believers that ultrasound can diagnose it, there are lines in most publications that say we cannot see the superficial subtype. So this is giving us a little bit of optimism. Now, here are some features of superficial endometriosis on ultrasound. So we have fluid in the pelvis, of course, giving us that advantage. We have the vagina, we have the uterosacral ligament, and just here we have a hypoechoic irregular area. In this picture, we have a very similar view with this hypoechoic area disrupting this very smooth peritoneum over the back of the vagina. This is the proper peritoneum over the posterior vaginal fornix. In this picture here, we have a nodule, which historically would have been described as superficial because it measured less than 5 millimeters of depth to the peritoneal surface, though now probably would be considered in the realm of superficial endometriosis. As a surgeon, there is still controversy in my mind around these classifications. And that's because some surgeons will use excision techniques to take away endometriosis and others will use ablation techniques. And so something like this would really, in my mind, need to be excised to be properly treated. Though if somebody has been classified as having a superficial lesion, some people's mentality may be that it is appropriately treated with ablation. So there may still be some intricacies in the descriptors that we use for superficial endometriosis or the measurements that allow surgeons to better decide on the treatment for that specific lesion, for that specific patient. In this video, what we're seeing here is the back of the uterus. The probe again is in the posterior vaginal fornix. And with a very slight jiggle, we can see hyperechoic foci that are moving on the peritoneum of the posterior vaginal fornix on the back here. In this video here, we have a very small hyperechoic focus sitting at the interface of the pelvic sidewall and the uterosacral ligament on the patient's left side. As we scan through that video, you'll see that very small, very subtle lesion come back right there. These are really challenging to see. They require this detective mentality. And that's at baseline my mentality. But it is a teachable skill. And over the past year and a half, I have had the privilege of supervising fellows who are already OBGYNs. They are doing a fellowship in advanced surgery and advanced ultrasound. And at the beginning, of course, they couldn't even find a bowel nodule, which are large. And now a year and a half into it, they're pointing out these subtle features to me, and I'm so proud of them. They are able to find superficial endometriosis in a short time. So for those of you listening who are already doing ultrasound day after day, that learning curve will certainly be shorter because you already have so much of the baseline skill. In this video here, we have the anterior surface of the uterus at the fundus. Again, using that jiggle test, we can see these movements of tissue that are on the serosa, the peritoneum of the uterus here. And in this video here, again, this may now be classified more appropriately as deep endometriosis, but what we're seeing is at the very base of the pouch of Douglas, right, pause it on the spot, right here, right at the base of the pouch of Douglas, not quite into the RVS, we have this hypoechoic area that again is less than 5 millimeters, but certainly very small, very hard to see. But if you look and with fluid there to help you, you can see it. I'll leave you with this last line. I firmly believe that the diagnosis of endometriosis is therapeutic for our patients. It does give them a radiologic visualization of a disease that has been historically very challenging to diagnose. And many people believe still that laparoscopy is the only way to diagnose it. By giving people a non-invasive diagnosis, you allow them to have clarity on what is going on in their body. You allow them to have decision-making capacity that they wouldn't have otherwise if they were having that diagnosis at laparoscopy. And it gives them this freedom, this control over a disease that has wreaked a lot of havoc on their lives. In the fertility population, the first few slides here demonstrate that a diagnosis of endometriosis is going to help their process of conception. And so, in my mind, diagnosis of endometriosis is therapy for these patients. And I would encourage everybody to be really diligent and be that detective to try and help them understand what's going on. I'd like to thank everybody again for your time. There is another QR code here, and this includes some of the references for the studies talked about today, as well as other interesting things. And we're happy to talk at any point through social media or email. Take care.
Many thanks, Matthew, for that cutting-edge talk on superficial endometriosis. And if I can come to some the questions that are coming in here online, but one of the first ones, Matthew, relates to the amount of saline. That's when we look at these images and the subtle findings that you are seeing in terms of these peritoneal deposits. There's a reasonable volume of saline in the patch of Douglas after injection. So how many 20 ml syringes or syringes do you load with saline, and how much do you inject?
Good question. So the first thing to say is in the study that we did, the proper diagnostic accuracy study, we had a median of 60 cc's of fluid. So, not too much. And in historical studies where people tried to use fluid in the pouch of Douglas for various things, including ectopic pregnancy diagnosis, people used up to 300 cc's of fluid in awake patients. In the original work, we would do traditionally about 30 cc's of fluid, 20 of pure saline, and 10 of a combination of saline and gelaffusion. That was the technique at George's practice for looking at fallopian tube patency. And in those patients, that 30 would usually be sufficient to get a preliminary assessment. The more fluid, the better, is the truth. The more fluid allows more things to space out. So, have we settled on in a awake patient population what the ideal fluid is? No, not quite. But 60 was what we had in the study, and that gave us those diagnostic metrics.
Because that's a lot more than you would put in with the saline assessment of, a standard saline for assessment of intercavity pathology would be 5 mils. So it is a lot more. So how do you select your patients that you're going to choose to put in that volume of fluid? How do you select out the group who you're suspicious about superficial endometriosis that would benefit from this test? So firstly, if you're scanning patients for fertility or for pain, you're going to do an assessment for deep endometriosis now. This is something that doesn't require any fluid. You're going to assess for deep endo of the posterior compartment, anterior compartment, ovarian endometriosis, adhesions, etc. In those who have what I would describe as a negative deep endometriosis assessment, they are the population who would be most eligible for infusion of fluid to assess for superficial endometriosis. I will argue, and I think most of my patients would agree with me, that they want to have clarity as much as possible. Most people are very willing to have a laparoscopy.
And while laparoscopy is very safe, you could die at laparoscopy. Bad things can happen. So this is certainly less invasive test than laparoscopy. It's obviously not going to be as accurate as laparoscopy, but if you do see something and have the ability with the studies behind you to say, this that I am seeing is real, you can provide somebody with a diagnosis and get them on the right trajectory, which of course may include laparoscopic surgery, but at that point, it's not so much diagnostic, it's therapeutic. So, I think if you were to start to offer this to patients, I think people would jump at the chance because they are desperate to diagnose endometriosis. Maybe not specifically endo, but they're desperate to understand why they are in pain and or experiencing infertility.
Matthew, there's a question here from Marion McCaffrey. Is when you're looking at sonopodography, is that solely for saline, or is there also those who are using contrast media?
Good question. So in our original work that was published in the Journal of Ultrasound in Medicine, we had contrast as well. We had an agent called geliffusion that was agitated with normal saline, which is quite an interesting medley because it starts off very hyperechoic, but separates once it's into the pouch. So in those patients, the fluid agitated mixture settled in white, but then became anechoic. And so that allowed us to see. We had to wait a couple seconds, but I haven't done this with things like XM foam. I don't know what the, I don't know what it looks like when it actually settles in the pouch. Maybe yourself or Emmeline can speak to that.
Yeah, I would say that foam, just as it is within the uterine cavity, it makes things very difficult to see. And when you're talking about the minutiae of markers that you're looking for, I think you'd need to have a hypoechoic solution, not a hyperechogenic solution. Foam is hyperechogenic. Matthew, you mentioned the criteria of hypoechoic, hyperechogenic, and the number 5 is listed as filmy adhesions. How would you know filmy adhesions is just not, because when you do a laparoscopy, sometimes you see fine filmy adhesions and no endometriosis. How strong a marker is that out of the markers that you mentioned? To me, I would have thought it's a reasonably frequent finding around the fallopian tube post-ovulation. You see fine filmy adhesions. Not adhesions, filmy tissue. Yeah.
Yeah. So these are going to require clinical context. So in all patients who are coming for evaluation of endometriosis, we have to understand what's happened already to them. Very interestingly, in the world of diagnostic accuracy studies for endometriosis, there has never been a dichotomy in patients who have had surgery before versus not had surgery before, because surgery will certainly affect what the pelvis looks like. If somebody has had a surgery before or had some historic infectious entity, such as PID, appendicitis, those filmy adhesions certainly could be a reaction to the previous infectious entity and not endometriosis. But certainly something like PID historically can be another cause of infertility or pelvic pain. And so it's still an important thing to characterize in the context of their clinical history. But in the absence of that history, there are very few other, and the absence of surgery, there are very few other things in the pelvis that will lead to adhesions that are present. And this is not, the retrograde menstruation that might come from the tube where you see a little bit of a very mobile echogenicity. These are adhesions that are there and you can see their attachment sites. They're still filmy. They're kind of like sailing in the fluid. I don't have the exact numbers to tell you, this is going to be predictive in this number of people, but again, it's not a normal finding to have adhesions in a person who has either pelvic pain or infertility in the absence of previous surgery or previous infection. So I think it's a very worthwhile thing to document. It usually will mean something. And endo is going to be one of the most common things that it'll mean.
Yeah. There's a question here, Matthew, from Marwa, who's asked, says, thank you for your presentation, your nice presentation, and asked us, what is the risk of infection with this amount of volume infusion, and do you cover with antibiotics?
We don't cover with antibiotics. we would really extrapolate the numbers from the studies that have been done for fallopian tube patency, because this is not really any different. Maybe in terms of volume, it could be a little bit more, but why would there be an increased risk with more volume by a few cc's? So no, we don't. And I don't think that there is a reason to be concerned there.
Thanks, Matthew. There are more questions and we'll come back to these at the very end.
Simon, can I, I'll just add my, well, what I wanted to say is actually to add congratulations to Matthew. Listen, endometriosis is an awful disease, and we're talking here today about fertility, but it's really debilitating for millions of women around the world through chronic pelvic pain. I don't think we should underestimate as a medical community the time it takes for a woman to receive a diagnosis. It ranges between 5 and 11 years. Krina's study showed a median length of 11 years. That means half the women were longer than 11 years required to get this diagnosis. So, I wanted to congratulate Matthew and George, who's going to be speaking next, about the importance of creating good non-invasive methods to diagnose this disease. Not only does that make it much more accessible than laparoscopy and safe, but there are other problems with laparoscopy other than its safety. I mean, generally laparoscopy is a very safe procedure, but there are other disadvantages. I mean, the heterogeneity of the disease means that you might not see the lesions. There's poor correlation between the amount of lesions and the amount of symptoms that women have. And of course, there's also the cost. And not all countries have a publicly health funded system. Those that do mean it takes you a long time to get to laparoscopy. And those that are private means that you can have the laparoscopy tomorrow morning, but it costs you a lot of money. So I think whichever system you are in, creating good non-invasive methods for diagnosis of this disease are absolutely key. And I wanted to congratulate Matthew and George on driving this whole concept of ultrasound diagnosis. So thank you for that. Can I quickly introduce George, Simon? Because George is an old friend. We worked together for a number of years here in London. And it's been really wonderful to see how George has become a mega star in the world of gynecological ultrasound scanning. He's also a gynecological surgeon, in particular in endometriosis and minimal access surgery. And he's had lots and lots of positions in ASIM, in the World Federation of Ultrasound Medicine Biology, as well as in ISUOG, where he's currently the chair of the scientific committee. He's written books, he's written articles, but to me, probably the most important work is in his role in pushing the earlier diagnosis of endometriosis. And because of that, he's also now an ambassador of the World Endometriosis Society. So thank you, George, for sending your lecture in advance. George, unfortunately, has been taken ill. We hope it's not COVID, but we have a video from him, and Adnan is going to play that now, and then we'll come back to Q&A at the end.
Thank you and welcome to this masterclass where I'm going to bring together the technologies of advanced ultrasound imaging for endometriosis with advanced laparoscopic skills, particularly surgical skills, in relation to women with high-stage endometriosis. So when a woman presents with symptoms suggestive of endometriosis, for the most part around the world, women have access to basic transvaginal ultrasound scan. And what this means is that in the context of the presence of hard markers, when we're looking at the uterus and ovaries, so in the context of the presence of an endometrioma or hydrosalpinx, it's then possible to predict the presence of endometriosis in subsequent laparoscopy. However, when there's no hard markers present, then the conventional ultrasound reports that woman's pelvis as being a normal pelvis. Now, we all know from experience that a significant proportion of women that have a normal basic pelvic ultrasound scan go on to have endometriosis at laparoscopy. So what does this mean? This means that for these women, there's no detailed planning. It's a disciplinary approach by the gynecologist only. If there is bowel disease, then there's an unplanned intraoperative colorectal consultation. There's no bowel preparation. The patient doesn't have specific consent, so that consent does not include potential bowel or urological procedures. If the surgery is continued, then that woman is potentially subjected to suboptimal site reduction of their endometriotic disease at the first surgery, and as a result, there's the potential for higher complication rates. For the most part, a significant proportion of those women will have their surgeries abandoned. They'll get referred on then to an advanced endoscopic surgeon, and they'll have a two-step laparoscopic approach for their high-stage disease. In the ISWAB world, and certainly in my world, and hopefully for a growing number of women around the world, they do have access to deep endometriosis ultrasound scan. And so when we perform this scan in accordance with the IDEA consensus statement, then it's possible to predict high-stage disease, which in turn results in better outcomes potentially for women, because we've got now detailed surgical planning. It enables us to have a multidisciplinary team approach in accordance with the WES and NICE guidelines. And then women with bowel disease have a pre-operative colorectal consultation. Bowel preparation is arranged. The consent is specific to include the potential for certain bowel procedures and the urological procedures if the urinary tract's also involved. And because we've got the right people at the surgical table at that first surgical procedure, then it's possible to optimally site or reduce the disease with a lower complication rate, again, because we've got high expertise with multiple disciplines present at surgery. And because we're invoking the presence of colorectal and or urological consultants at the time of this gynec procedure, we can, for one step, laparoscopy, and in doing so, avoid a two-step laparoscopic approach. We've modeled the concept of the benefits of having access to deep endometriosis imaging at the first scan in a health economics paper that was published last year in the British Journal. And what we did, we divided two groups of 1,000 women presenting to a gynae ultrasound service, where the rate of endometriosis is around 10 to 15%. And in model one, these women had access to a basic pelvic ultrasound scan, and then we followed them longitudinally over the 12-month period, looking at the rates of two-step laparoscopic procedures, particularly for high-stage disease. And in model two, women were having access to deep endometriosis imaging, expert guided ultrasound at the first scan, and again followed them longitudinally over a 12-month period to see what their two-step laparoscopic intervention rate was. And based upon the cost of that additional surgical procedure in model one, we can see that for every 1,000 women, when we integrate deep endometriosis imaging, it's possible to save a service, a public healthcare service, more than $500,000 a year by avoiding that two-step laparoscopy. So there's a benefit not just to the patient, but also to the system that provides those services in the context of socialized medicine. Why do we need a multidisciplinary team? Well, we know that we get the best outcomes for these women if we've got, as I said previously, the right people at the surgical table at the first surgery itself. And so it's possible to then center our surgical approach on high-stage disease in women that potentially will need complex surgery. In order to do this, we need a reliable preoperative ultrasound tool. For some parts of the world, and particularly North America, MRI is that tool. Certainly in the UK, Europe, and Australasia, that non-invasive diagnostic tool of choice as a first-line approach is ultrasound itself. So I'm a strong advocate for ultrasound in planning endometriosis intervention, in particular endometriosis surgery. What are the potential benefits? Why do we need to do an ultrasound before we proceed with a potential endometriosis surgery? Well, it's important to understand the status of the urinary tract, to have an understanding of the pelvic sidewall, the state of the pouch of Douglas, and to know whether or not there's the presence of rectosigmoid disease. So I'm going to focus on some of these aspects in today's masterclass. So here's a situation where we have a woman that presents with obviously symptoms suggestive of endometriosis, and at her deep endometriosis scan, she's got a uterosacral ligament lesion that's extending laterally into the parametria with a result hydroureter. And we can see that that woman indeed at surgery had a uterosacral disease extending laterally into the parametrium, resulting in a hydroureter. So with preoperative consultation with urology and a planned procedure, this one was scheduled for and successfully underwent a left-sided ureteric reimplantation. We know that from work from Shannon Reed's unit and also in unpublished data from our unit, that it's possible to assess the mobility of the ovaries, and in particular if the ovaries are fixed either inframedially to the uterosacral ligament or laterally to the pelvic sidewall, then under these circumstances, these women will need to have a ureterolysis, which is a complex surgical procedure which requires significant training and skill and understanding of anatomy and also understanding of avascular spaces. And so here is an ovary that's fixed to the uterosacral ligament, partially to the pelvic sidewall, and probably even somewhat to the uterus. And then we needed to perform a retroperitoneal ureterolysis from pelvic brim down to the ureteric tunnel itself. So we can see the ureter here crossing the bifurcation of the external and common iliac and heading down caudally towards the ureteric tunnel. So having mobilized and normalized the anatomy, visualize the ureter, mobilize that ureter infralaterally, then enables us then to focus on the central posterior compartment disease, and in doing so avoid complications to the ureter itself. Having understanding of Pouchy-Douglas's obliteration is also really important, because we know that in women that preoperatively have an obliterated Pouchy-Douglas, they're 3 to 4 times more likely to have underlying rectal disease. But more importantly, when it comes to the surgical planning of these women, we need to have a really clear understanding of our anatomy, our avascular spaces. We need to know how to perform a ureterolysis. We need to know how to understand to open the medial and lateral pararectal spaces. And in order to get below the rectal lesion, we need to also open up the rectovaginal space. So our knowledge of anatomy, rectal anatomy, avascular spaces is critical. And knowing that we'll need to invoke these skills pre-surgically based upon assessment of the Pouchy-Douglas using the sliding sign, which was work published from our unit under Shannon Reed's PhD back in 2013. And we can see now, I'm going to show now comparative videos from women that have both their ultrasound performed and laparoscopy. So these are matching ultrasound and laparoscopy videos. So on the left side, we can see that this woman's got a obliterated Pouchy-Douglas with a negative sliding sign. She's got underlying torus uterus disease, and she also had a rectal lesion. So when we operate laparoscopically on this woman, we know that she's bowel prep. We've got our colleague involved who's colorectal, and we plan this as a joint procedure. And the bulk part of this surgery is going to be to normalize the anatomy before even tackling the disease from the outset. So if this woman gets to go to a generalist, she will need a 2-step laparoscopy, so we can avoid that those unnecessary steps by planning surgery by doing a detailed deep endometriosis ultrasound scan. When it comes to the rectum, it's really important that we have an understanding of normal rectal anatomy on ultrasound scan, and the more we see normal, then we're more likely to understand abnormal rectal pathology when it presents itself. So at the beginning of the ultrasound scan, and I did a live scan yesterday for Canon, which is available online today as we speak, but it's important as we place that probe inside the vagina at the start of the scan, we're looking at the retroperitoneal rectal anterior muscularis here, the rectovaginal septum, and the vagina. And almost in all circumstances, below the level of the cervix, the rectovaginal septum present tends to be normal, and it's very rare to see low rectal disease. So this is normal anatomy. As we then move above the level of the cervix, and we now are looking at the upper rectum, so this rectum is visualized and visible at the time of laparoscopy, and this is a video from the same patient where we've got normal anterior muscularis, posterior muscularis, and we can follow that rectum to the above the rectosigmoid and to the sigmoid and beyond. And in my hands and my team's hands, we don't use bowel prep. I think Simone Ferrero's groups published a randomized controlled trial, and there was no improved diagnostic capabilities of ultrasound when they used no bowel prep versus bowel prep in picking up rectal disease. So it's a preference rather than necessity. So we know what the normal looks like. So this now enables us to have an understanding or to appreciate abnormal rectum. And so we can see here we've got a lesion in the anterior rectal muscularis propria, but we've got a positive sliding sign. So again, we plan to do a joint case, and this woman with the stills present had a normal Pouchy-Douglas. Here's the anterior rectal lesion. She had conservative rectal surgery, which was a discectomy done laparoscopically with a primary closure, and she did very well with her procedure. So ultrasound helps to visualize the surgery, tell us about the status of the Pouchy-Douglas, and then also plan the surgery based on the fact we knew that there was a rectum nodule present, but that rectum was mobile itself. In more advanced disease here, we've got an anterior rectal lesion, and now we're in the left hemipelvis, and this is partial obliteration to the left of the midline, and we can see quite clearly that correlates also with the laparoscopic view. So we've got an anterior rectal lesion, we've got that fixed probably to the torus, and it's invading into the uterosacral ligament to the left of the hemipelvis, and we can see that that matches up nicely with a anterior rectal lesion with partial obliteration of the pouch of Douglas to the left of midline. And in the same patient, having normalized her anatomy, she underwent a combined gynae colorectal case, and this was a segmental resection and primary reanastomosis. In our hands, in my group's hands, we've got data now on 140 cases, and we've got a high rate of segmental resection. And we tend to be more aggressive in our surgery, and we've got a leak rate of 1%. We feel that the rate is low from a leak perspective because we're dealing with young, fit women who tend not to have comorbidities. They've got no vasculopathies as the rule, vasculopathies. They're not diabetics. They tend not to smoke, and they're usually lean, so they tend to do well with a primary anastomosis, which is very different to the outcome that you see in rectal disease in much older patients who tend to have a higher leak from a primary anastomosis. This is another example here of an anterior rectal lesion with a degree of partial obliteration of the pouch of Douglas, and then that matches up beautifully at surgery with a rectal lesion, partial obliteration of the pouch of Douglas, and this patient was scheduled for a joint case, hysterectomy plus segmental bowel resection, again with a very good outcome. Moving on to the next case, again, we've got another matching ultrasound video and laparoscopic video. Again, we've got in the midline here a rectal lesion that's fixed to the torus itself. So we've got obliteration of the pouch of Douglas, a torus lesion, that lesion is fixed, and you've got a pleomorphic reaction in the pouch of Douglas, and we can see quite clearly that correlates nicely with an obliterated pouch of Douglas. Now, if you don't do an ultrasound pre-surgically, we've got no idea what's driving those rectouterine adhesions. So the importance of performing an ultrasound scan is not only to get an understanding of why that patient has rectouterine adhesions, but what's driving those rectouterine adhesions is going to be very critical in the planning of the subsequent surgery. And in this case, the woman's got rectal disease. She's got an obliterated pouch of Douglas. She's got fibrosis in the pouch of Douglas. She's also got the presence of torus uterus diseases. It's really important when we assess the rectum, if we see one lesion, then to look cephalic to that. In this situation here, we've got a very large anterior rectal lesion, and then cephalic to that, we've got a second rectal lesion here. So there's a lower rectal and an upper rectal lesion. This extends over a 7 centimeter segment of the rectum itself, and this again correlates nicely with the presence of fixation of the pouch of Douglas, rectouterine adhesions, and multifocal rectal disease. When on ultrasound we find rectal lesions, it's important to measure the distance between the anal verge and the most inferior aspect of the most caudal lesion so that we have an understanding of the distance to the anal verge. And unfortunately, most rectal lesions tend to be more than 6 to 8 centimeters from the anal verge. And I think this is also another reason that there tends to be a low rate for performing an ultra-low anterior rectal segmental resection with a covering eyelid, a defunctioning ileostomy. And again, nice correlation between multifocal rectal disease and what's seen at laparoscopy. And again, here's another example of an anterior rectal lesion and a higher anterior rectosigmoid lesion, and again, with fixation of the pouch of Douglas. Now, again, if you've got that laparoscopic view for the first time, not knowing ahead of time what the ultrasound showed pre-surgically, again, you would have absolutely no idea of what's driving those rectouterine adhesions with complete obliteration of the pouch of Douglas. So the ultrasound pre-surgically enabled us, again, to plan the surgery. We cystoscope these patients at the start of surgery. We put in ureteric catheters. We then move to the laparoscopy. My team then normalizes the anatomy, performs the ureterolysis, opens the pararectal spaces laterally, medially, the perirectal space, the rectovaginal space. Then we're below the rectal lesions, then hand over to the colorectal team to then perform the segmental resection. In this case, we've got multifocal disease. And again, here's an example of that reanastomosis at the time of laparoscopy after we've removed that diseased rectum, and we're now joining up the upper rectosigmoid or sigmoid to the actual rectum itself. So in the context of there being a primary reanastomosis. And again, without needing to perform a defunctioning ileostomy, because as I said previously, these lesions are high lesions. There's a low risk of leak in young women, and also because they're high lesions, there's a low risk of rectovaginal fistula as well. And ultimately, here's an example here of the diabolocyme, where we've got a vaginal lesion that's contiguous with an anterior rectal lesion, and when we go to the vaginoscopy, we can see quite clearly that there's endometriosis herniating through the posterior vaginal fornix. And then when we move to the laparoscopic view in the same patient, we can see quite clearly that there is indeed pouch of Douglas obliteration, as that rectum is fixed to the torus, fixed to the back of the vagina. And not until we dissect out and mobilize the perirectal spaces, mobilize the rectovaginal space itself, and get below that lesion, knowing ahead of time that there's going to be potentially be a vaginal lesion. So we perform the colpotomy deliberately. And as we look through that colpotomy, we can see the disease from above now. So there's those little vesicles of endometriosis that we saw at the vaginoscopy. So now we're going to do an en bloc dissection and remove the vagina, separate the vagina, allow it to be fixed to that uterine segment, and perform a segmental resection, close the vagina, do a primary anastomosis. So that the ultrasound is really critical in the planning of the surgery for these women. And the final slide, again, we can see here quite clearly to the left of you, we've got, as we follow that anterior muscularis of the rectum itself, we've got a very large rectal lesion that's just under 5 centimeters in its sagittal length. And again, that correlates with the presence of pouch of Douglas obliteration, which was predicted and indeed was the case, as you can see in the matching laparoscopic video. And we had planned, scheduled, ahead of time, consented, bowel prep this patient to have a joint procedure. And she underwent normalization of her anatomy, opening of avascular spaces and the segmental resection of her rectal disease. So to summarize, I think preoperative ultrasound holds the key to planning surgery, particularly in the context of an MBT approach. And for those with high stage disease that involves potentially the urinary or gastroenterological GI tract, it's absolutely critical. And in doing so, I think we can improve the outcomes for these women. We maximize cytoreduction with the first surgery. We enable the consent to be specific, not only from the patient's perspective, but also from a surgical planning list perspective. We know what instrumentation we need. We know how long the surgery is going to take. And in having that multidisciplinary approach, I think in turn we can reduce the risks of to the patients and reduce the complications, and in turn improve the outcome for these patients. Thank you for your care. Thank you for your care. Thank you for your time.
Thanks very much, George.
Thank you,
Iris.
Simon. Because George isn't with us, I wonder whether I'm sure Matt can talk to some of the questions today. But I'll let you lead the Q&A, Simon, since this is your area of expertise and not mine.
I'm happy for you to manage. I'm easy either way, Iris. I mean, I thought it was a fantastic talk, giving the correlation of ultrasound findings with surgery. Probably one of the best talks I've seen on deep endometriosis, rich in that correlation of clinical and surgical findings. Let's do it together, Iris. The first, Matthew, are you there?
Yep, I'm here.
Matthew, there's a question. It probably relates more to your talk than George. We'll deal with both at the same time. But it's in this situation where you find superficial endometriosis. This is from Apostolos. When you find superficial endometriosis in a 25-year-old girl, would you suggest prophylactic use of progestogens?
Well, so if you diagnose endometriosis, it's not really prophylactic. It would be therapeutic as a medical option. I would certainly discuss the treatment options with a patient who has a non-invasive diagnosis of endometriosis, which include do nothing if it's not actually causing any problems. I suppose if it's not causing problems, that's maybe where the question comes from, if it's prophylaxis rather than therapeutic. No, I would not usually if they're fine. But discuss other options as well, including surgical therapy, complementary alternative therapies.
And Matthew, could I ask you to comment maybe on the role, this is a question that's come in from Eva, on the role of CA125 monitoring, both in evaluation and diagnosis of superficial and deep endometriosis, if you could comment on its role.
Thus far, there have not been studies differentiating the subtypes of endometriosis and the utility of biomarkers, including CA125, on the diagnostic performance. All types of endometriosis have been clumped together. no society in Canada, Australia, UK, I'm not familiar with every society in the world, but those that have big guidelines suggest using CA-125 as a diagnostic tool. It is generally thought to be not valuable because it's not got high diagnostic test performance, and it can be, in many women, harmful if you diagnose them with an endometrioma on imaging and they have a high CA-125. The lack of expertise in truly knowing that it is an endometrioma may lead to patients being referred for further unnecessary imaging, further assessment by gyne-oncology specialists who also don't truly understand endometriosis. I mean, none of us do, but their mindsets are very cancer-oriented, and unfortunately, there have been way too many ovaries lost for patients who have a marginally elevated CA-125 and an ovarian endometrioma. So I feel very strongly that it should not be used in all comers. However, I do think that we do need to dichotomize those with ovarian and deep endo as and superficial, because maybe there is a utility for biomarkers, especially CA-125, in superficial endometriosis. We just don't know yet.
Yeah. There's another question here, whether you're able to distinguish between endometriosis and tuberculosis. And I guess that becomes relevant in India, I think, because I've seen some very nice presentations by Ashok Khurana on tuberculosis, pelvic tuberculosis. Do you have any comment to make about that endo versus? I'm guessing there's not too much tuberculosis in your neck.
No, not much. I have only had experience with one patient who emigrated to Canada with pelvic tuberculosis, who had ovarian cysts. This was before my time scanning, so all I had to look at was the report. But there was enough clinical suspicion that we did an endometrial biopsy and confirmed the pelvic TB. I wonder if Emmeline has more experience as a broader radiologist with MR, CT, ultrasound, in the different, and also maybe the patient population, Perth, closer in proximity to some places with TB.
I have to say no, thank you, Matthew, for asking the question, but we don't have any TB in Western Australia, or well, I would say very little TB in Western Australia. I have seen a case when I worked in Singapore though, and same as you, it was 25 years ago or something, and it was an endometrial biopsy that proved it. But yeah, I have very little experience with imaging in TB of the pelvis, so sorry, I have not much to add to that.
Emmeline, if I could ask you though, in relation to tubal patency testing, there are some other technologies that are being used, B-flow and using color Doppler technologies in assessing tubal patency. I think it was actually quite popular here in Melbourne for a while before foam arrived, when agitated saline was used. There were many groups around town that were using color Doppler to assess whether there was flow and patency in the tube. Have you any experience in that, or a comment to make the role of color?
Yeah, I try it often when I'm using Lepidol, because I do, Lepidol, unless you agitate it, you don't see it so well. So the visibility on ultrasound is limited. So I use color Doppler, and sometimes it works and sometimes it doesn't. So I would say in my hands, it's not very good, but that's in my hands.
Yeah. And as you say, it is an outdated thing, that there are a lot of those who are using it all the time, and I guess they became familiar with it, but there's so much movement and blood flow in the pelvis, and when you are looking at towards the pelvic side walls, that I think it becomes quite difficult, particularly with the newer Dopplers, slow flow, and then the power Dopplers. I think it's hard going, but maybe with color Doppler and very PRF dependent. But like you, I don't feel the need to use it, I guess, in the sense that foam is so good and so clear when there is tubal patency established. Iris, did you want to ask a question, or will I keep going?
Do you know, the main thing that I noted from the questions and from the many thousands of people attending today, and thank you everyone for attending, is quite how interesting a subject this is. And I think, Simon, my takeaway message today is we must do another program on maybe specifically on endometriosis, taking a little bit more into account some of the surgical aspects maybe, and doing that comparison that you were talking about, which is so crucial. But this is clearly an area that's very, very emerging. In obstetrics, we would never dream of trying to do diagnosis invasively if we can get away with non-invasive diagnosis. Going in to take a fetal blood sample for anemia is gone because we've developed non-invasive methods of detecting anemia. That doesn't mean that the gold standard is not still doing a fetal blood sample. As it is in endometriosis, the gold standard will still be to do a laparoscopy. But what it means is that you can get quite far down the track of stratifying your population and deciding who will most likely benefit from surgery. So I think this is a really, really interesting subject. Thank you.
Yeah, we're sort of thinking about maybe mid-year or something coming back to endometriosis because it is so popular. The questions keep going on here. I don't know if I think it's getting pretty late at night. Maybe we'll just take one or two more. There's been a question coming through here, Matthew, with regard to the role of color Doppler in evaluation of endometriotic deposits, whether that is a role to play in helping you arrive at a correct diagnosis.
No, not really. Endo is very fibrotic. A deep endo is very fibrotic. Doesn't have that significant blood flow. Though endo is a disease that causes angiogenesis, it's just not demonstratable on ultrasound. The utility of Doppler with an ovarian mass is important. So if you have something that looks like an endometrioma, of course, at baseline, put your Doppler on your ovaries and ovarian masses. But for deep endo and superficial endo, no, not yet.
Yeah. Emmeline, in the setting of identifying a hydrosalpinx where you proceed with tubal patency, how often do you find that the tube is patent?
Well, it's interesting you ask that because quite often I don't actually do the hycosi if we see a hydrosalpinx. It depends on my referrer. So I normally give them a call first and ask them whether they want me to do it. So it's very hard for me to answer that question because often I don't actually do the procedure at all if we see hydrosalpinx, just because they think that that's a very good cause for subfertility. They're going to treat it anyway by resecting the tube. There's no point in me actually doing the tubal patency test. I don't know if the rest of the panel agrees with that, but certainly my main referrers don't like me doing the test in the setting of hydrosalpinx.
I agree with you, Emmeline. I think I have reservations about putting in fluid if there's a hydrosalpinx there, which is, evidence of potentially infection, not necessarily, maybe endo. But then you've got to question what's the reason that you're doing the test if you've got all the features that the tube is damaged. I guess if it's unilateral, the other tube looks normal, and you want to establish patency on the other side, and the patient's not a candidate for IVF, maybe. But these are rare and far between, really, for us to give a broad overview. And I don't know of any published data supporting that you go ahead or refrain. It's on a case-by-case assessment, I think. Just a quick word, Emily, I'd like to know your take on intravasation of contrast. We see that reasonably frequently on ultrasound. How does that appear on HSG?
I did show a case on HSG alongside. I don't know if my slides can come up again. I'm happy to share that, but it's much more, it is actually very obvious on HSG, but the issue there is that when we're doing the fluoroscopic screening, we're doing it in the room with screens with quite low resolution. So sometimes we don't pick up the really subtle intravasations, whereas I reckon I see intravasations so much more on ultrasound because of the TV probes being such high resolution. So actually, I don't think I overcall it, but I think I just see it more often on ultrasound. And then sometimes I get back to my reporting room on, following a HSG, and I look at it on a high resolution monitor and I go, oh crap, there was intravasation. But usually it doesn't matter because we're using water-based contrast there, and we're not, with Lepidol, I'm really, really careful in making sure that there's no intravasation at the time, and we are very careful in looking hard.
Would
both.
you explain for giving Lipoidal if there was intravasation?
Well, this is interesting. I did a seminar with the World Endometriosis Society there on endometriosis and intravasation, and the room was quite divided. So there were people who are very conservative, but like me, I'm definitely on the conservative side. If I see intravasation, I generally don't tend to give Lipoidal because I just sort of feel I would rather do no harm. Other people were a little bit more cavalier, I would say, in the attitude in saying, look, it probably doesn't matter if it's only a little bit and it's mopped up by the lungs anyway. So a lot of things, I know that my interventional radiology colleagues give Lipoidal all the time and without any problems, and they don't really consider intravasation. But I think we ought to be very careful, and I do not give Lipoidal in the setting of intravasation.
Thanks very much, Emily. The last, maybe, sorry, go ahead.
I want to ask Emily a question, whether, or Simon, do you think there may be some relevance to intravasation when we're looking for adenomyosis? So could intravasation help us understand the pathology of adenomyosis, the diagnosis of adenomyosis on ultrasound?
Super good question, because I've actually thought that there might be a correlation between the two. I just don't think it's well studied. I don't know what Simon thinks about that.
And look, I don't see that association, Matthew, in terms of tubal patency testing that's more commonly seen in adenomyosis. As a diagnostic criteria, it would be nice to have something that would improve things, because it's a little bit of a mess at the moment as to what are the criteria for the diagnosis of adenomyosis. But intravasation is, well, I say it's often enough. It's still pretty infrequent, every year I might get maybe 4 or 5 intravasations, and endometriosis is present in 40% of the patients that I scan. Well, maybe not 40%, but in that age group of 35 to 55, it's 40% of them have adenomyosis. So I think its frequency in which you see intravasation, I wouldn't be too optimistic as it being a useful criteria in the diagnosis of adeno. But as you mentioned, adeno, maybe Matthew, one of the closing questions here is, I think we know there's an association between endometriosis and adenomyosis. Can you tell me how tight that association is between superficial versus deep endometriosis?
Yeah, I'm honestly not convinced that studies have dichotomized those two subtypes of endo and their relationship to adenomyosis, though we can probably extrapolate a little bit from a study that Katerina Exakoustos did looking at adenomyosis and endometriosis association in adolescents, who will definitely be more on the side of superficial endometriosis. So I don't have the numbers exactly clear in my head, but I think in those that had a diagnosis of endo in the adolescent population, 40% had adeno. And most of the adolescents will have a superficial type endo because it just has not had enough time to become infiltrative, though there is, of course, theories that some endometriosis is seeded from embryologic development and stays dormant until menarche, and in those cases it may actually be deep endo from fetal times entering into Eris's world. But I think we need to understand a little bit better the intricacies of the relationship in superficial endo and adeno, deep endo and adeno, and the various types of adeno, because there are the in to out and out to in type adenos, those with the deep endometriosis in the posterior compartment. There's the entry of adenomyosis into the uterus via the serosa. So there's different types of adenomyosis that we need to start to characterize better as well.
We've been 2.5 hours on the go. I think I want to thank you both for your fantastic presentations, and also George in absentia for, I think, probably one of the best talks I've seen George give. It was a terrible pity he wasn't here to join us, and I hope he gets better soon. But it's been great having you all, and I see there's a final question or suggestion, Iris, coming in here from Joe Aquilina, suggesting that in covering endometriosis in the next session. That correlation with MRI is something that we should be considering going forward. And I'm sure, Emmeline, you'll be back to join us on faculty. And I'm sure you may add comment on the radiological perspective of MRI and endo. Iris, do you want to pass any closing comments?
Just to say thanks to all the speakers. Thanks to all your delegates. Thanks, Joe, for joining from London. And listen, I'm extremely grateful for all your contributions. And to all of those listening, have a lovely holiday season. This will be our last program for this year, but we will regroup in early January. And we will continue to bring you Scan Academy webinars. We started this when there was virtually no educational material online for people doing ultrasound. There's now many people who offer good programs. Most of them are paid for. We are still committed to bring you free education, best education. And with luck and with COVID going away, hopefully we will also be able to do eventually a physical meeting in order to see you all in person. So thank you from me and have a lovely day.
Thanks. Take care.
Recording stopped.
Hi, Matthew. See you soon.